Thank you. Good morning, everyone, and welcome to the June meeting of the Group Insurance Commission. Thrilled to be in front of the group that is watching via YouTube. So welcome. We encourage all GIC members and constituents to be as engaged as possible. And we love this opportunity to have so many folks have access to our meetings. At this point, I'm going to ask Andrew Stern to just let folks know who is on the commission. I'm Valerie Sullivan, and I'm chairman.
Thank you, Madam Chair. Present today are the following commissioners, which are essentially all of our commissioners. Vice Chair Kaplan, designee Archibald for the Secretary of Administration and Finance, designee Butler for the Commissioner of Insurance, Commissioner Shabbat, Choate, Clenard, Davis, Guerin, Edmonds, Gentile, McEnany, Jennings, Rodriguez, Sinenko, and Commissioner Timothy Sullivan. Commissioner Chapdelaine will be joining us momentarily.
Oh, thank you, Andrew. And for those of you who are watching via YouTube and don't know Andrew, he is our general counsel here at the Group Insurance Commission, a long-standing servant and good lawyer for us. So thank you, Andrew.
Thank you, Madam Chair.
At this point, I'd like to ask a motion to approve our minutes from our May meeting.
So moved.
Seconded.
Okay, any discussion? All right, well, at this point, then I'm going to turn it over to Andrew again for roll call, and I'm a yay.
Thank you, Madam Chair. Vice Chair Kaplan,
Yay.
designee Archibald, I'll move on. Designee Butler,
Yay.
Commissioner Shabbat,
Present.
Commissioner Choate.
Present.
I'm assuming present means you're voting affirmatively for the
Yes.
the
Yes.
motion. Thank you. Commissioner Clenard,
Aye.
Commissioner Davis,
Aye.
Commissioner Guerin. Remember to take yourself off mute.
Yay.
Thank you. Commissioner Edmonds,
Aye.
Commissioner Gentile,
Yes.
Commissioner McEnany,
Aye.
Commissioner Jennings,
Aye.
Commissioner Rodriguez,
Yes.
Commissioner Sinenko,
Yay.
and Commissioner Tim Sullivan.
Yes.
And I'll go back to Commissioner Archibald, designee Archibald.
Maybe he's abstaining because he wasn't at the last meeting.
Which is fine.
Yes, I abstain. Sorry about that.
Thank you. And let me just see if Commissioner Chapdelaine has joined yet. The vote passes with one abstention.
All right, great. Thank you, Andrew, and thank you, commissioners. And I'm going to now turn it over to Matt, our executive director, to give us the agenda and to start the meeting. Thank you, Matt, and good morning.
Good morning. Thank you, Madam Chair. Thank you, members of the commission, members of the public who have joined us for this meeting. As you can see, we've got a very full agenda and an extended meeting today, so thank you for your forbearance there. Today we will have several presentations. We'll have a presentation by staff and some colleagues from Willis Towers Watson about prescription drug costs that we held over from the prior meeting. We are also joined today by our esteemed colleagues from the Health Policy Commission and the Center for Health Information and Analysis, a presentation that we typically have in the fall, but which has been delayed due to a delay in the annual cost trends reports due to COVID-19. We will also have a joint presentation, again, with our colleagues from the Health Policy Commission and CHIA around health equity, picking up where we left off in our fall meeting on that topic. We will also have a report out from Paul Murphy of our operations unit on the results of our recent annual enrollment. And we have, per usual, our typical CFO report and 2 votes relative to authorizations for trust funds. So we've got a busy agenda ahead for us today. Next slide. Great, thank you. So I'll speak to just 3 specific items on the Executive Director's report today. Per usual, we have the written report submitted to commissioners as part of your packet, and we're happy to take questions on any items noted here on the agenda. So the Dependent Care Assistance FSA plan, which you'll note as bullet number 4, we presented on this in the last meeting and indicated at that time that we would continue to monitor developments in Washington, D.C., specifically relative to a potential increase in the contribution limits. We have seen no new developments that would lead us to recommend at this point that we do so, but we're happy to take any questions or thoughts on that item before I move on.
I don't see any hands up.
Commissioner Tim Sullivan, I think.
I see Tim. Go ahead, Tim.
Yeah, regarding the increase in dependent care is allowed under the American Rescue Plan, I just want to let you know that I've been contacted by the MTA leadership and some members requesting that the GIC implement the increases allowed under the law. Now, I appreciate your research on the issue and understand the rationale for not implementing the allowable increase at this time. However, as you just mentioned in your report, the GIC, you indicated the GIC would continue to monitor developments and any potential federal legislation raising the withholding amounts permanently to $10,500. It is my hope as we move forward that the GIC will advocate for and be supportive of any such legislation that might make such an increase permanent. Thank you.
Thank you, Commissioner Sullivan. I appreciate those comments, and I think it's important for us to know that there is interest in the potential to raise the contribution limit. We certainly have no objection to the concept of doing so when there's an expressed and demonstrated need. So we will certainly continue to monitor this situation for additional opportunities and as you suggest, to advocate with our colleagues in federal and state government for that to be a possibility. So thank you, Commissioner Sullivan.
Thank you.
The second item I want to note, unless there's further comments on Dependent Care Assistance Program, FSA. Seeing none. So just a brief update on our office move. As commissioners will recall, we are slated to move from our current address at 19 Stanford Street in the Hurley Building up to the McCormick Building at 1 Ashburton Place. That we are in the home stretch now, preparing for that move, which will actually take place starting a week from tomorrow and will be done by a week from Monday. So we are, as I've discussed with the commission before, at the very front of the line for state agencies to adopt a hybrid work model as described by the governor and the Future of Work initiative. We are, in fact, the very first agency to implement this model in real time. We do not, so this is an office move of our physical stuff in the office at Hurley. We do not anticipate having staff back into the office in any significant numbers until after the summer, and we await additional guidance and instruction from the governor on that. So we're really excited about this move. We're going to have a very modern workplace. Our staff is strongly supportive of the model that we're implementing here. So it's a big event on our end. I want to thank a number of my staff, I won't single them out, who have just been tremendously understanding and helpful as we execute this office move. Happy to pause there if there's any questions on our office move.
Bobby, did you have any questions or anybody on this? I'm excited to see the new office, even though it's not officially back to work yet. I hope I get an invitation to come in, Matt.
Absolutely. I see Commissioner McEnany has her hand up.
Yeah, I'm just curious. So after Labor Day, will GIC adopt a hybrid model on a permanent basis?
Yes, we certainly are. And I'd say the principles that are guiding this will be essentially that you're in the office when you need to be in the office. You're working from home to the degree that it is appropriate and allows you to conduct your work responsibilities. There will always be the unique circumstances where maybe the home environment for some of our staff may not be particularly conducive to that. So we'll be able to accommodate more of an in-office presence for some of our staff who need that. We are adopting a model of no one has an assigned space, including yours truly. We will have reserved spaces using sort of a neighborhood model where there'll be an office where kind of the executive team can use and reserve it, as will other functional units within the department. So we are the model, and we intend to implement it in a way that is true to the principles that have been expressed by the governor in the Future of Work initiative. So we're really excited about it.
Thank you.
Hey, Bobby, I see you have your hand up.
Yes, I do. Thank you. First, I want to say that I'm looking forward to a tour of the 16th floor, and also appreciate your GIC moving to a hybrid model for staff, which I think is great. And I just wanted to, unfortunately, the little hand did not display previously. So I just wanted to comment on the decap and say that I concur with Commissioner Sullivan and appreciate all the research and the work that you've done regarding the FSA and the allowable increase, but understand obviously the reasoning for not proceeding at this time, but do concur and hope that GIC will participate if there is any legislation moving forward.
Thank you, Madam Vice Chair.
And just to note, Matt, Adam has joined, so I wanted to make sure that was on the record.
Thank you, Commissioner Chapdelaine. Welcome. So the last item I want to flag here is, actually, I'll hand it over to Andrew relative to contracts that we will need to have commissioners sign. Andrew?
Thank you. As the commissioners recall, you authorized us to move forward with contracting following procurements for healthcare consultants and the Life and LTD. I'm pleased to say that we are finalizing those contracts. The Life and LTD group has been assiduously working to transfer the business over from Hartford to Met. I will be forwarding through DocuSign signature pages to you for those two contracts. I'm asking that you please have them signed as soon as you get them. We need to have them signed by the end of the month. Thank you.
Thank you, Andrew.
let me
Okay.
just say that if anybody would like to see the full contracts, just let me know and I can make them available.
Thank you, Andrew. And I just want to acknowledge the work of Andrew and his legal team over the last 6 months or so, as we've had a very steady stream of work related to contracting, as this is the first optional year for our 6 health plans and our 2 PBMs. So it's been a tremendous amount of work. So thank you, Andrew, and your team for that.
Yeah, no, concur. Christy has her hand up and so does Bobby. So go ahead, Christy.
Thanks, Valerie. My question is about our meetings going forward after Labor Day. What's the expectation there? Are they going to continue like this, or are we going to meet in person?
It's a great question. Thank you for that, Commissioner Kleiner. So the statute that was, or the legislation that was signed by the governor yesterday that allows remote meetings through April of 2022 gives us some flexibility here. I will be working with the chair to determine, how we start addressing the potential of having some in-person aspect to the meeting, starting in our September meetings. So and we will be in touch with other members of the commission to get a sense of what your comfort level is about coming back into a physical location. So we will have the ability to do that in statute, and are willing to implement this in any way that the commission deems to be most appropriate.
Yeah, I agree with what Matt has said. There's definitely value in occasional meetings in person, but we also want to make sure people are comfortable with it and have ample notice, not just for commissioners to get into Boston, but also to have staff be able to plan for getting back to in person. So there's some logistics to put together. I would love to see everybody. So we're trying to balance safety with, missing seeing all of you in person with making sure that logistically we can do it. So stay tuned. We're working on it.
Yeah, so the 21st floor of Ashburton, which we typically use for our in-person meetings, I think there's been some changes to the way that that's going to be programmed going forward. So it may or may not be in that room. But I can tell you that we will have the capability of doing a hybrid meeting of, certain members who want to be in person can be in person, and we'll be able to dial in those who prefer to be remote. I think that's a feature that I would like to make a permanent feature, particularly for those, Commissioner Chabot, among others, who travel significant distances to actually get to an in-person meeting. So we'll be carrying forward a hybrid model there as well.
Yeah, and don't forget, Commissioner Gentile, I think, comes the farthest. So
Yes, he does.
it's always does a good job getting here. So, all right, I don't see any more questions about that, but it's a good question, Christy. Thank you for asking it, and stay tuned. And then Bobby, did you get your question addressed? Or did you have another? She's on mute, so I'm guessing she's all set. All right.
I am. Sorry. I don't know. I think my laptop's not working today. Anyway, Commissioner Clenard raised the very same issue I was going to about the legislation that was just passed.
All right. Thanks.
So
Bobby.
thanks.
Thank you. All right. Continue, Matt.
Right, had myself on mute. We'll just take a very brief look at the calendar. Most of this is a retrospective look at the busy spring that we've had. As I've expressed before, what we've attempted to do during the spring is to give the commission a real thorough grounding in the primary challenges that we face to accomplish our objectives. We will be very busy, though there will be no meetings in July and August. On the staff side, crafting a framework for our procurement strategy, engaging with a variety of stakeholders, experts, and policymakers. When we return to the fall, or in the fall, we expect to have very rich discussions with the commission regarding potential strategies that we can employ to address these challenges. I expect that, when we convene in September, we'll be able to lay out a very full plan that will bring us to the release of an RFR and ultimately recommendations back to the commission for a vote to affirm the recommendation of staff. So we've thought of it as really seasons. The spring season has been about educating you and educating those who follow the commission. And in the fall, we're going to really start to roll up our sleeves and evaluate potential strategies working with you all. So we look forward to doing that. All right, next slide. So here I want to turn it over to Devin Shaw, our primary contact on prescription drugs at Willis Towers Watson, and Janine Dewar, our manager of pharmacy and ancillary benefits. Again, this is a presentation on prescription drugs, the last in our staff-driven modules. Last meeting, we took a deep dive into provider prices and behavioral health. Today, we'll pick up on prescription drugs and dig into some of the troubling trends, I would say, from a financial perspective, driven largely by specialty drugs. So at this point, I'll hand it over to Devin Shaw from Willis Towers Watson and thank him in advance for all the work that he does for us on prescription drugs.
Yeah, no, and Matt, I just want to add a thank you to WTW and Devin and Janine. We were supposed to have this last month. We ran over, and so the topic was too important to try to rush for the May meeting. So thank you for the flexibility and welcome back to present today.
Oh, welcome. Good morning, everyone. So my name is Devin Shaw, and Janine and I are going to take the next few minutes and walk everyone through, the prescription landscape and what's happening in the world of PBMs. I think, Janine, if you're on the phone, I can't see you on the screen, but I believe you were going to kick us off on the first pharmacy slide.
Yes, I'll kick us off. Good morning, commissioners. Next slide, please. So in FY 2019, GIC carved out prescription drug coverage, and the GIC's two PBMs are Express Scripts and CVS Health. Express Scripts administers pharmacy benefits for our non-Medicare members, and CVS administers benefits for our Medicare members. GIC delegates certain functions to our PBM vendors, including those related to member services, claims administration, negotiation of drug prices, and care management. As directors of these benefits, the GIC is responsible for oversight to ensure that our PBMs are acting in the best interest of our members by delivering quality and value. The GIC manages day-to-day work with our vendors, and we leverage Willis Towers Watson's experience and knowledge to optimize performance of our pharmacy plans. So with that, I'll pass it over to Devin to further discuss pharmacy cost drivers.
Absolutely. So if we sort of flip over to the next slide. So this chart on the left shouldn't come as any surprise to most of us. I mean, we have definitely seen prescription drug costs rise dramatically over the last couple of decades. And it kind of started in the 90s when what I call the innovation cycle kicked in, and the pharmaceutical industry has done a phenomenal job in coming up with a lot of products, in treating a lot of chronic conditions. And we've got treatments today that historically we hadn't had in the past. Along with that comes sort of the higher, ticket price, and we've gone in 1990 spending roughly $90 billion in prescription drugs to little over $350 billion today. So obviously, we have seen that costs go up as we have seen more and more products come in the marketplace. What does this mean to the GIC? So speaking the most recent data that we have, the GIC is spending roughly $900 million every year in prescription drugs. And that represents roughly 30% of the total healthcare spend. Pharmacy used to be less than 5%, 10% in the 80s and 90s, and now it's up to 30%. And it's expected to go up even further in over the next few decades. both medical and pharmacy trends are expected to exceed most consumer price indexes for years to come. And in the chart below, we're showing you sort of the, what the trends are looking like for the next couple of fiscal years. So the way to read this chart is the top two rows represent medical trend, and then we've broken down that by non-Medicare and Medicare. And you'll see they're roughly in the 4%, 5% range generally, but look at prescription drugs. They're almost double than what we in terms of what we're expecting for trends coming forward. And part of the discussion today is sort of walking the commissioners through why we see those higher trends. What does that mean to our members? What does that mean to the plan and our vendor partners?
So Devin, can you help us understand why there's such a difference in trend projections for medical between non-Medicare and Medicare? Like what's driving the more than double? Is it pregnancies or?
So we can take that back. I'm not sure if I'm sort of qualified to respond to that, but we can certainly take that back.
Devin, let me just take a quick whack at that. I think one of the things that we learned from our presentation at the last meeting around provider prices is that rising provider prices on the medical side are among the really core drivers of rising trend. These Medicare trends signify or reflect the rise in Medicare-based prices, which of course are governed by or set by federal regulation. So it's really the difference between the government opportunities to limit price increases, whereas on the commercial market side, it proceeds in a much more unconstrained manner.
Yeah, no, thank you, Matt. I wanted to make sure we were all aware of that difference because it's stark, and when it jumps off the page, you see it. So is there an opportunity here in the state to replicate some of the things that the federal has done to keep that trend a little lower? So thank you.
And Commissioner Sullivan, I'll add to sort of the pharmacy side, we see slightly lower trends on the Medicare side, only because some of the newer drugs we're seeing will end up being covered as in Medicare Part B as in boy, not in the EGWP plan. That's why, there's a slight difference between the pharmacy trends between commercial and Medicare.
Thank you.
Okay. So if we go over to the next slide, and this is sort of, we want to walk from, okay, the drug costs are going to go up and up every year. What have we seen historically? Again, if you look at this chart, we're seeing that the plan costs have increased over the last couple of fiscal years. But what's also important to understand is look at where the member cost is. The member cost has stayed essentially flat over the 3 years, and that's sort of the function of the co-pays and the deductibles and their sort of share after the premium. The point we're trying to make over here is as we keep the member share flat, and that's the one that members are exposed to, all the increases that we're going to see in the plan spend will be translated directly to the premiums. Right, so members are going to see that sort of higher prescription drug spend come out of their paychecks instead of necessarily coming out of their out-of-pocket costs at the point of sale, which is the pharmacy. Okay, any questions on that? Okay, so if we go to the next slide and spending a little bit of time on, why are drugs so expensive? And I think this chart is something that I brought to the commission last year when we were talking about the prescription drug program, but I think it's worth bringing up again. So what makes the pharmaceutical landscape very different? So first and foremost, drugs are often covered by patents. So the patent protection for the pharmaceutical industry is absolutely important, which allows now the companies to set prices without competition for a defined period of time. And that time is usually 19 years by the FDA, after which other companies can essentially replicate that molecule, and they call it generics at that point, which in the free marketplace, again, as you can imagine, as more companies make the products, the drugs prices will fall. But while the products are in that patent protection period, it allows the pharma companies to recover, some of their investments they've made in terms of bringing the product to the market. What we've also seen is drugs that are off patent, that means those that have gotten are generics now, based on the product, there might not be enough producers in the marketplace. So for example, when we talk about generic drugs like amoxicillin or furosemide or hydrochlorothiazide, which the last two that are used for hypertension, they're very frequently used, and there's a lot of companies that'll make them. But there are obscure products for infectious disease, for cardiovascular conditions, for psych conditions, where there isn't a huge marketplace for these drugs. And when there isn't a big marketplace, there aren't a lot of producers making these drugs. So then if we're limited to one or two manufacturers, that will creep up on the price point. So we've definitely seen that. Biological drugs, these are drugs that we started seeing the last couple of decades. They're a lot more difficult to manufacture. They cost more. It's not as simple as a chemical formulation that's put together. So that inherently requires a production facility and ongoing quality assurance and management, which is a lot more expensive than your traditional products. The FDA here in the U.S., as we all know, is prohibited from considering price upon approval, so leaving it up to the manufacturers to determine what the market would bear for its price. I mean, this is very unique to the pharmaceutical marketplace, which in the U.S. compared to the rest of the world. Medicare also, who is the largest drug purchaser, is prohibited from negotiating drug prices. So this is kind of what makes the U.S. very unique. Now, given that everything that we spoke about, there are certain things that the GIC can do and have done in the past to make sure that they sort of keep this benefit sustainable in the long run. So first and foremost, the GIC plan encourages use of generics and lower cost pharmacies for chronic medications. So this is evident in the way the plan is designed for copays, the way the network is designed, so that's automatic, that in a way steers people to the lowest cost point channels. Formulary is a big tool that's used by insurance companies and PBMs to sort of manage the drug mix. A formulary is essentially a list of drugs that are either covered at the lowest member cost share, medium cost share, and then a higher cost share. And as there's higher value drugs are drugs that are a lot more effective, a lot more prevalent, and cost less. They're usually placed in the lowest tiers. And the GIC has very good formulary compliance rates, almost in the high 90%. So that shows that the plan currently in place, both for the Medicare and the non-Medicare populations, is consistent with how medicine's practiced in the Commonwealth of Massachusetts. Third most important things are vendor contracts and oversight, and the GIC team here, kudos to them. And we spend a lot of time making sure that we're constantly looking at the contracts and looking at the financial guarantees, the performance guarantees, making sure that all steps are in place to put corrective action where there might be gaps. And that takes a lot of time and effort, but I think it's absolutely critical and important to make sure that we have a well-oiled a vendor partner in both ESI and CVS. The contract also is structured such that the members pay the lowest cost between a discounted price at a pharmacy, what's considered a UNC, that's usual and customary, and the planned copays. So it's, you guys are probably all aware of the Walgreens programs, the Walmart programs. I think Amazon recently announced a 6-month program at $6 for some generics. So the way the contract is designed, members benefit from that lowest discounted price at the pharmacy. If that $6 is lower than the $10 copay for the plan, then the member pays $6. That's essentially how the plan is designed, as long as the day supplies within the 30 or the 90 days at the pharmacies. So I think that's a very good feature, because as the retail programs evolve, we want to make sure that the members aren't forced to pay a higher price than what they can purchase it at a retail pharmacy. And finally, the price transparency tools, both at CVS and ESI, allows members to shop for drugs and pharmacies for their own particular treatment, and also look for alternatives before they even purchase that drug. And those tools have, we've seen a lot of utilization of those tools as members make choices.
Yeah, Devin, can you talk a little bit more about those tools? Because I had thought we had discontinued one tool, and I'm not familiar with the value of the tools that the PBMs offer to their members. Is that something that's specific on a CVS website or ESI's? And how do our members get to those tools?
Yeah, good question, Commissioner Sullivan. So typically when you log into ESI or CVS portals, you get access to your own prescription records, your EOBs, your claims history. Within those portals, there is a way to sort of price a drug. So it allows you to get a real-time price of drug. You can put in your drug amoxicillin. It actually maps you to your address if the tool has it, and gives you a price for, I think, like 15 or 20 pharmacies in the surrounding, like a 2-mile radius or 5-mile radius. So this way you can actually shop around and say, oh, listen, my amoxicillin is $3 at Stop and Shop and $3.25 at Walgreens, and I'm just sort of making it up, and which then allows you to say, okay, well, do I want to go to Stop and Shop for the $3, or do I continue to go to Walgreens where I get my other medications and pay that extra 25 cents?
Okay, thank you. Hey, Anna, I see you have your hand up, and I know this is an area of expertise for you.
Thanks. Yeah, I was just curious if there's any way to get a sense for how often these tools are used by our members. I think, across the nation, there's sort of this knowledge that these tools aren't used very often by people who are eligible for them. And it'd be really great to have that data on our members, because it might inform sort of how useful they are and how much we want to, think about this as a feasible strategy versus others, or how we might direct members to this tool if we think it's has potential.
Mm-hmm.
Yeah, and we absolutely have data, so we can definitely get the data from both vendors. To answer your other question, do I think the tool is getting used enough? No. I don't think members are thinking about that extra step before they go to the pharmacy. Most members will go directly from a doctor's office to the pharmacy to pick up the drug, and sometimes they don't try to price a drug. Most times members will learn to use the price of drug tool is when they get that sticker shock at the pharmacy, and they're like, well, geez, what do you mean I have to pay a deductible and then a copay on top of that? For GIC specifically, because the deductibles and the copays aren't as large, so like in a high deductible health plan where members have $3,000-4,000 deductibles, those plan members are more likely to use these tools. But in a plan like GIC, I am not surprised that we don't have a high utilization of the tools. But yes, we can absolutely promote this and figure out ways to get more member engagement in this.
Yeah, no, good.
Yeah, if I could just follow up, I think you make a really good point about the copays being low, and that given that, there's not a lot of incentive for members to shop, and that would suggest that we don't want to rely too much on something like this as the GIC thinks about how to manage costs.
Yeah, agreed, Anna. So thank you. I totally agree. Hey, Eileen, I see you have your hand up, and then Bobby, I see yours. So go ahead, Eileen.
Great, thank you. Thanks for the presentation, and just kind of building on Anna's point. So the tool that allows people to shop prices assumes that a patient leaves the office with like a physical prescription. But in my experience, when you're at a doctor's office, they ask you where you want it called into, right? So the tool isn't available at the time, excuse me, at the time of decision making. So it raises a couple of questions for me. One, are there ways to encourage doctors to do that, I guess. And then secondly, it does beg the question, are pharmaceuticals, much like the rest of healthcare, where it's a small percentage of patients that consume the vast majority? And if so, is there a way to better manage that population?
Yeah, great points, Commissioner McEnany, and I'll sort of take the first things first. So I think your first point was around, how in the modern day, how prescriptions flow, and doctors are no longer writing a prescription or calling the pharmacy done electronically. PBMs have done a good job in sort of integrating the formularies into the EMRs now. So most physician offices, when they use Epic or any of the EMRs, they actually have connectivity with the PBM. So at the time of prescribing, a physician, in the perfect world, would know what they're prescribing, and if there are any PAs, they can do electronic PAs. The price part is not available to the physicians, from what I understand. I think so that is a slight disconnect, because you're absolutely right. The members are going to go to the pharmacy not knowing what drug is being prescribed to them. So I think that is sort of the new thing that needs to be solved for. And from what I understand, there's some thought leaders in the PBMs who are trying to figure out, how do you take that data from the EMR and connect with the physician, with the member, and send them some sort of a text message in advance. But that's like, I think we're still out a couple of years, but there's innovation happening in that space to sort of solve for that.
Okay. All right, thank you. Hey,
and then could I just follow up on the second part of the question about, is the prescription usage concentrated in a small group of the overall?
And yeah, and that's a great question. And yes, I mean, I think generally speaking, we see almost 70 to 80% of all enrolled members use prescription at least once a year. So if you sort of follow that algorithm, most people, have an acute, antibiotic or some sort of a cream. Then you've got the chronic users, which are typically 20 to 30% of your members. But most chronic users use generic drugs, so they don't cost too much money. Then we're really down to like the 2% of the members that use expensive specialty drugs. And those 2% of the people will almost account for 60% of your total drug spend. So I know I'm jumping ahead of time, ahead of the gun over here, but that is absolutely the case, that a very small percent of members will account for the majority of the drug spend. But there are a lot of chronic drug users out there who use generic products, and we'll sort of speak about that and the value these products bring to the marketplace.
Yeah, no, thank you, Devin. We've got about 15 more minutes on this, so Devin, talk fast. But
Okay.
I know, Bobby, you still have a question. After your question, let's maybe hold questions until the end. Go ahead, Bobby.
Yeah. Okay, sorry. I was just curious, the being a member myself, right? Most of or all of my prescriptions, unless there's some reason to get an antibiotic, right, are through Express Scripts. So there is no opportunity to shop around for better drug prices, certainly. And so I'd be very curious what the percentage is, or what the numbers are of the ESI users, and then the CVS or Walgreens users. And the other point I want to make, that as a member, these pricing tools are not heavily advertised. I would dare say that very few people are even aware of them, because we encourage members to use Express Scripts, right, for 90-day, or if you're really sick and you go to the doctors, right, and they, send a script to a pharmacy near you. Mm-hmm. Most people, I would imagine, whether their children are sick or they're sick, are not thinking about price at that point. And so I think there's a huge sort of disconnect when you were talking about the pricing tools, I mean, barely do they make a dent as far as the membership is concerned.
Yeah, good point. And I'll sort of end by saying that, I think it's important to make these tools available to members, to the extent that they use them. I mean, imagine a world where the tools weren't made available to the members. I think that would be a bigger problem.
A good takeaway from us here is that I think, have some opportunities to think differently about how we engage with our members and educate them about the options that are available to them, and maybe shopping better at the point of sale, with Anna's comment as important context there. So we can give this some more thought as we contemplate our strategies for prescription drugs and talk more about this in the fall. So thank you all for that good feedback.
Yeah, no, it is good feedback. So Devin, 15 minutes.
Yep. Okay, so I'll walk through the next couple of slides kind of fast. If you go to the next slide, sort of wanted to give you, and this is illustration to give you a sense of what are some of the levers, that we see that have an impact on trends. So if you imagine your drug spend in year one to be $100, typically utilization will go up year by year as treatment intensity goes up, as more and more people get drugs. So that typically adds to the trend. Unit costs obviously are about 6 to 10%. This is what you pay for drugs. Drug mix is an important factor, and that's typically a trend increaser, and that's because we generally see when new products in the marketplace, whether it's diabetes, depression, hypertension, there is this marketing that happens of these branded products. And oftentimes physicians and members will say, well, I want the latest and the greatest in drugs. So drug mix is, you still have the same number of prescriptions in a given drug class, but the average cost is higher. So that's sort of the drug mix. And I'll sort of get into that. Some of the trend deflators are increasing network discounts. So, as we contract with the PBMs, we want them to get better and better discounts from the pharmacies. Plan management is often a trend deflator with programs like prior auth and step therapy and all these different things that will add sort of to sort of a more efficient drug program, decreasing costs. And finally, rebates. Rebates definitely have a negative impact on trend. So all in all, I mean, and the numbers don't add up. I mean, I think the numbers should add up to 102 at the end of the second year. We have a mathematical issue, and we just somehow have 104, but that should be 102. If you go to the next slide, just wanted to walk you through, what are some of the things that we typically see, and I'll go clockwise from utilization all the way down to other factors. So the factors that influence drug trend for utilization is usually, new indications for chronic medications. We typically see this in the autoimmune conditions like rheumatoid arthritis and psoriasis and IBD. So it's the same drug now, but the pharma companies have, saying, okay, well, it also can be used here and psoriasis and psoriatic arthritis. So that sort of adds to utilization. Obviously, consumer demand for marketed products, as we see commercials every day. And then finally, pharmaceutical innovation. And I think, with COVID sort of lurking in our rearview mirrors, if I could use that cautiously, I think, that's a good example of how not everybody's getting vaccinated. That's pharmaceutical innovation at its best. But I think, we're much better as a society because of that innovation. In terms of unit costs, again, this can represent new innovation, but as I've mentioned before, we also see large increases for some of the older, less prevalent generic drugs. We've talked about PBMs using formularies and step therapies and networks and all that stuff to sort of keep a cap on the unit costs. Drug mix I talked about. Generics often have a negative impact on trend as a product goes generic, all of a sudden the price point drops and the drug mix is a lot more affordable than it was before. Biogen's new Alzheimer's drug, I'm not sure if you guys have seen this, but that's an example of how advances in science will lead to better treatment and higher cost. Here's a drug that was was some of us thought, would not make it to the market based on the advice from the FDA advisory committee, but ultimately the FDA commission overrode them, and now the product is going to be commercialized pretty soon, which will definitely have an impact to the GIC and the plan. And then finally, treatment intensity, as diabetes is a good example of how, there used to be 2 or 3 oral meds and you went to insulin. Now the gap between oral meds and insulin has sort of widened as there are more products that sort of fill the gap in between them. So that's sort of treatment intensity. And then obviously the other factors such as out-of-pocket costs and treatment choice by providers, engagement tools, and finally rebates. So if we move to the next slide, this slide I think is important because it sort of talks about the 4 different big categories of drugs. And I'll start with the top one. Generic drugs, generics. I mean, it really is sort of the cornerstone of any affordable drug plan. 87% of all prescriptions are generics today, so that's almost 9 out of 10 prescriptions. And they cost $22 a script. So, very affordable for the plan, for the member. It's good medicine, well proven and well established. Multi-source brands are brands that have generics available now, but for many reasons, a physician or a provider may decide to keep the member on brand. We see this in conditions like anticonvulsants, and we see that in ADHD, where in spite of having generic available, providers will still like to stay with the branded products. Usually 1% of your total claims, so we're not talking about a lot of claims here, and the cost is about $306 per claim. Single source drugs are drugs that don't have generics. If you think about asthma and diabetes, there's a lot of products there that don't have generics, and these are the ones that are covered by patents. So obviously, that's about 10% of your total claims. Average cost is $470. The one to pay attention to, though, is the last bucket, specialty drugs, and we will probably have a separate session just on specialty drugs. So I'll save some time on that, but just understand that's 2% of your claims and roughly $6,200 to $6,300 per claim. And that's where, we're seeing a lot of trends coming from and a lot of focus in terms of management. So I'll save that for the next session. The next couple of slides are just quick metrics on, how ESI and CVS are performing. So if you start to the chart on the left, I mentioned 2% of specialty drugs, driving 63% of your cost. Your generic dispensing rates at 88%. I mean, that's excellent. I mean, that just shows how efficient the plan is running. The members are responding appropriately by taking generic drugs. And at the bottom, what's near and dear to me is sort of what I call the quality metrics of compliance rates. That's one thing that we can't really take our eye off. So when you look at the high prevalent conditions like diabetes, hypertension, you want to make sure that cost is not a factor, access is not a factor, and we're providing good products, good drug mix, and good pharmacies. And I think all of that is sort of evident from the high compliance rates that we continue to see for these chronic conditions. One other thing, just a couple of things that I want to call out on the key insights, and I'm not going to sort of read them all, but I think it's important to say that in the last couple of years there's a focus on opioids and managing opioid conditions, and we saw a 15% reduction on members taking short-term opioids and a 27% reduction in the use of long-term opioids. And this is not because members are not in pain. It's not that members are not getting surgeries. They are getting all the procedures and surgeries done, but I think better management tools through the programs that they have in place to definitely have an impact on sort of the available opioids in your medicine cabinet, which often is the number one way that people get started with opioid addiction. If you go to the next slide, very similar metrics on CVS for the EGWP population. you'll see here specialty spend is now 44%, not the 60+%. And part of that is because a lot of the specialty drugs for Medicare are covered under Part B as in boy on the medical side. But again, similar metrics for generic dispensing rates, compliance, member cost share, again, is very affordable at 8.4%. So, you know, we're very pleased with sort of the metrics we continue to follow on both the plans, CVS and ESI. To go to the next slide, you know, again, we'll come back and talk about, you know, why specialty drugs and then the fact that, you know, how it's going to reach $310 billion by the year 2030. But there are a lot of sort of unique features about specialty drugs that sort of make them expensive for consumers. There's definitely a growing pipeline. I think, you know, 3 out of every 4 products in the pipeline are specialty drugs today. We see very few patients, less competition, significant investment in R&D. But now understand, we're talking about treating conditions that are rare now. We're talking about some very rare, obscure conditions that didn't have treatments in the past. So I think, you know, that sort of goes into showing where pharma is investing these days, and, you know, they'd rather invest in treating and finding a cure for an oncology condition rather than finding the next antidepressant. Not, you know, not that that's not important, but I think, you know, there is more reward for them in sort of researching sort of those elements. With specialty drugs come a lot of testing, REMS programs, which are programs to make sure that you know, patients are not harmed for their products, and it's ongoing oversight of safety for these drugs. And then finally, there's no viable pipeline for generics in the specialty drugs like there is for the non-specialty drugs. So we'll definitely come back to this for future years, but this is just sort of a primer for the next discussion. And then Janine, I think I'm going to pass it over to you to sort of wrap us up with, you know, some of the things we have done and the results we've seen from those programs.
Thanks, Devin. So this slide details pharmacy plan updates and savings over the years. And some of the key takeaways are that the GIC is constantly looking at efficiencies and opportunities that will benefit members and control overall costs. Pharmacy management programs and contractual terms have delivered significant savings since pharmacy was carved out in FY 2019. But still, costs primarily driven by specialty drugs continue to outpace the savings opportunities. Next slide, please. So the good news is that the GIC pharmacy plans are running efficiently. There's strong member satisfaction with both of our PBMs. Again, specialty drugs continue to be the leading cost driver, but the GIC will continue to monitor pharmacy programs and our vendors. And as Devin said, we'll devote some time to providing more detail on the challenges of specialty drugs at a future meeting. I'm happy to take any questions.
So before we go to questions, I do want to note that the presentations by our colleagues at the HBC and CHIA, which will be next on our agenda, also include a number of kind of data points that they're seeing around prescription drugs and specialty drugs in particular. So that won't be the end of this discussion at this meeting on the challenges of specialty drugs. But thank you, Devin and Janine, for that presentation. I think, you know, a lot of things are going well. I think there are a number of features of our current contracts with PBMs that are providing a lot of value to us. Generic dispensing rates running really high, but it is specialty drugs that will continue to be the focus of our efforts going forward. So happy to pause here for questions before we move on to the next agenda item.
Yeah, Matt, I don't see any questions. So we are almost back on track. So that means that I am going to make one comment or a question or a suggestion, maybe all of the above. But Devin, you said that at a future meeting, we are going to talk about specialty drugs. I don't know if that's been planned, But my request would be to really bucket specialty drugs and maybe get granular because, you can include oncology drugs in specialty. You can include the very rare, orphan drugs in specialty. And, you had the average cost of specialty drugs at $6,900 a month or some number there. But there's a wide swath where some, CF drugs are hundreds of thousands of dollars a year, and other specialty drugs are, more like $2,000 a month. And so there's such wide variability that it's hard to truly understand specialty drugs for our members, our constituents, our commissioners, if you don't get granular and be specific in different therapeutics, different use cases, and maybe have a couple of case studies, of course, not disclosing any PHI, of what that usage looks like in our members and how those drugs are actually helping those patients and those members. It's just as a suggestion.
Great suggestion. Yeah, thank you,
Madam Chair. We will certainly take that back for future discussions.
I still don't see any questions. I won't ask another. So we're back on track. Thank you, Deb. Thank you, Devin and Janine. Turn it back over to you guys.
Great. Well, thank you, commissioners, and thank you, Devin and Janine, for your work in this area. At this point, we're going to move on to our cost trends presentation from the HBC and CHIA. One of the real delights that I have in stepping into this role at the GIC is to be able to work with David Seltz and Ray Campbell and their respective teams. I want to thank them for taking the time to present today. After their presentation, we will pause for a brief break before we move on to the next topic. But thank you, Ray and David, for joining us. And I think at this point, we hand it over to Ray Campbell from CHIA.
Thank you very much, Matt. My name is Ray Campbell. I'm the Executive Director of the Center for Health Information and Analysis, also known as CHIA. And it's always a pleasure to appear at the GIC. I've had a number of different roles with the GIC, from staff member to commissioner. So a lot of friends at the organization. It's a great organization, and it's definitely a pleasure to be here and tell you a little bit about CHIA, what we do, and how it kind of intersects with the work that you're doing at the GIC. So next slide, please.
Ray, you're a little bit modest. Ray was acting executive director for several months, and we appreciate your service. So thank you.
Thank you so much. All right, so if we could go to the next slide. So what I'm going to do is, before getting to some slides that talk about this year's cost trends results that we released back in March, which was later than normal. We shifted the timing somewhat as a result of COVID, but there were also some other data collection reasons why a slightly delayed timing actually works somewhat better in terms of the precision of some of the estimates we do. But anyway, before getting to the actual details of our findings in the annual report, I just want to put CHIA in context for the members of the GIC so you can understand us. We do a bunch of work with the GIC, but I think that's actually going to accelerate for a whole number of reasons. And so looking forward to doing even more with Matt and his team. So what is CHIA and what do we do? Because we are a little bit unusual. Not every state, actually no other state, has an organization quite like CHIA. Massachusetts places a greater emphasis on measuring its healthcare system than any other state in the country. And that largely, I think, is a result of the second bullet, which is that we have a long history in the state of innovation, not just in healthcare delivery, but also in healthcare policy. And that's an area that really benefits from having more data for better decision making. And so CHIA's mission, we were created in 2012, combining some legacy operations from different agencies, but also with some entirely new mandates. Our mission is to create the factual foundation to support better healthcare policymaking in Massachusetts. Our data gets used by the legislature, gets used extensively by the Health Policy Commission, the Department of Public Health, the Executive Office for Health and Human Services, certainly the GIC, the Commonwealth Connector Authority, lots of private researchers, including a commissioner on the GIC. And so our data feeds into not just the work that we do, but also the work of lots of other organizations. I should say, in going through CHIA's data and the analytics we do, you'll notice we focus primarily on the healthcare system. The Department of Public Health really focuses on health and wellness, diseases, vital statistics, things like that. It's more on the clinical side than we are. It's more on kind of the outcome side. She is focusing primarily on the healthcare delivery system, although of course that overlaps a lot into the interactions that individuals have with the system. And so it's not, that distinction isn't absolute, but just as we go through this, you'll notice that this is very much about the healthcare system, and that feeds into the policy making that Massachusetts does in this area. The way we do that is we were given extensive authority by the legislature to collect data from really all the major healthcare stakeholders, health plans, provider organizations, hospitals, nursing homes, community health centers, and others. And we use that authority to collect a lot of data and build a number of key data assets. And so I'm going to go quickly through the next few slides. There's really a lot of detail behind it, but it's data stuff, so it's probably not worth drilling down too much for this audience, but happy to answer any detailed questions you have about this, of course. But essentially, CHIA curates a number of major data assets, and then we release a lot of reports and publications on some major areas that I'll show to you. And then separately, we work kind of behind the scenes doing custom work with different state agencies. So next slide, please. All right, so I'm going to describe quickly, this is just this slide and the next one, CHIA's major data assets, because that, in a lot of ways, it defines a lot of our work, and it defines a lot of the analyses that we're able to do. So we collect lots of data, about 25,000 different submissions per year from over 1,000 data submitters, and we curate a number of major data assets from this data. First, the hospital discharge database. It's one of our oldest. This is patient level information on every single discharge from every acute and behavioral health hospital in the state. Lots of times the interesting things in healthcare aren't happening in the hospital. Certainly for the COVID pandemic, it was primarily a hospital-based phenomenon. And so the hospital discharge database has given us tremendous visibility into the impact of COVID in Massachusetts on the state's residents. We also have an emergency department database that is a patient level record, once again, for every single visit to every emergency department in the state. We have an all payer claims database. It's not really all payer, it has certain gaps in it, but it's a huge repository of claims information from Medicare, Medicaid, and fully insured commercial health plans. And so it's much of the market. We don't use it for running totals because it does have certain gaps, but it's a huge repository for drilling down on utilization and spending in healthcare. The final bullet point on this page, payer expenditure reports. Because the APCD has gaps, we have the luxury of having the statutory authority to require health plans to report to us on their total spending. So there's no gaps in that. And so we can collect these aggregate expenditure reports from health plans, work with actuaries to build pictures of the total spending in the Massachusetts healthcare system. And that's the foundation of our annual report, the slides that I'll be showing you in a little bit. So payer expenditure reports are very powerful. We require health plans to tell us how much they've spent, and they have to break it down in a whole bunch of different ways to our specification. So they break it out by service categories, they break it out by member zip code, so we can see where they're spending this money. They break it out by product and market segment. We require them to disclose cost sharing, lots of other information, but it is aggregate data, and so you can't drill down further, and that's why we have the APCD, or the hospital discharge database, where we can get into more details. Next slide, please. Okay, so the last three types of data assets that we curate: provider financial reports. We collect lots of financial information from hospitals, from nursing homes, community health centers, in conjunction with the HPC, from medical groups. And this is both classic financial information, but it also has sort of a healthcare or clinical component to it. So from hospitals, we ask them about their bed capacity, number of licensed beds, nursing capacity, different things like that. So it's financial information, but it's also heavily supplemented with healthcare information as well. Statewide surveys, these are really interesting and important. Every other year, so biennially, we do a survey of households and then employers. These are very significant efforts. We use a national survey vendor of 5,000 respondents for the household survey, and it gives us a really detailed look into issues like coverage, affordability, uptake, plan design, lots of interesting things about the healthcare market, both from the perspective of people buying commercial insurance and also for the perspective of employers offering commercial insurance. And the Connector Authority is a big consumer of our survey data, and I think the GIC does, and probably increasingly in the future. It's just interesting insights into what motivates actions by consumers. And then lastly, registered provider organizations, that's the medical groups that send us financial data. Okay, next slide, please. There's just so much here, and I just won't, we could be here all day if I went into any depth, so I won't, but I'll just go down the list briefly. As I said, what we're looking at is really the system and its financing more so than kind of individual outcomes. There is a section on quality I'll mention briefly, but it really all starts with spending and utilization. That's really our core capability, is the ability to measure spending and utilization in the system. We also collect lots of data, as I mentioned, on provider finances. We use that data, among other things, to help set rates for the mass health program. We focus a lot on insurance coverage and healthcare affordability because it's a major policy priority in the state. And so CHIA does a lot of work in this area. The survey data that I just mentioned, but other information that we have, we measure and monitor coverage and enrollment trends very carefully. CHIA has always looked at health equity and social determinants of health, but certainly in the past year, with much greater interest and focus on this area, CHIA is both kind of reshuffling some of what we currently do to sort of highlight the data we have that relates to health equity issues, but we're also very aggressively looking to expand our data collection and reporting in this area. Behavioral health is an issue that Massachusetts has been a real national leader on it, and so it's something that CHIA has paid attention to for a number of years. We do a lot of work in this area. It's really amazing how much if you look at behavioral health in conjunction with just about any other issue in the healthcare system, you just see dramatic differences, whether it's readmissions to hospitals, whether it's spending on, whatever the category is, behavioral health is frequently a really important driver. Provider and payer quality, CHIA does less kind of direct work in the quality space because of the nature of our data. It isn't clinical, but we do run a lot of process type of measures using the data that we have. And we also purchase data and acquire data from other sources and aggregate it so that there's kind of a repository of quality information available about Massachusetts hospitals, nursing homes, and other groups. But we're not really in the business of creating sort of new metrics and such. The last category, we do a lot of work in the area of price transparency. Okay, next slide, please. This is the last one before I go on to looking at the annual report slides. But in addition to the data assets that I mentioned, and then in addition to the analytic activities that I mentioned on the last slide, we also do work that's, I guess, more custom in nature. And that's mandated benefit reviews for the legislature. Whenever there's legislation that would require fully insured health plans to add an additional benefit, we working with our actuaries, run the number on what the total costs would be and how it would impact premiums. We do a lot to support the HPC with data analyses and referrals. That's really kind of one of our highest obligations and sort of something we focus on very carefully. We also do a lot of interagency data sharing and analytics with other organizations. I mentioned them previously, so I won't list them again, but these are all entities that have some important role in our healthcare system. And we never have deeper data on their own population. So for instance, the GIC, we have your claims data, but you have much more information about your members than we do. But we can put that information in the context of the whole healthcare system. And because we can see the whole system, we certainly have more information about the providers treating your members than you do. So you can see your providers better, but we can see, you can see your members better, but we can see the providers better. We do a lot of work, and this has been increasing quite a bit in recent years, interagency data linking, linking assets either to the APCD or even sometimes different data sets that agencies have that are unrelated to ours. CHIA's expertise in linking is something that other agencies are coming to us for more and more. We support, we've also released a lot of data to the stakeholders in the healthcare ecosystem in Massachusetts, as well as researchers. And then lastly, we use kind of our data and our analytic capabilities to respond to major healthcare system events, whether it's the passage of the Affordable Care Act, the opioid crisis, or most recently COVID-19 and health equity issues. So let's flip from, let's go to the next slide. And this is now, we're going to look at some findings from CHIA's annual report this year. This was released back in the spring. This first slide, and I guess maybe before even starting in with the first slide, the top, the high end or the top line numbers from this year are that total healthcare expenditures in Massachusetts were $9,294 per capita. So $9,294 per capita. That was a 4.3% increase from 2018 to 2019. And so I should mention these are 2019 or 18 to 19 numbers when we're talking about growth rates. So over $9,000 per resident, 4.3% growth rate. Last year's growth rate was revised upwards to 3.6. So that's 2 years in a row we're above the state's benchmark goal of 3.1%. David Seltz can talk much more about the kind of the benchmark and the state's work in that regard. But so this slide, with that as a kind of a high level context, we drill down in our annual report on many, many different aspects of the performance of the healthcare system. And I encourage you to get the report from CHIA's website or have GIC staff circulate it to you. There's a wealth of information in there that really puts lots of different healthcare issues in context. But if you look at enrollment by benefit design, which is an issue I know that's important to the GIC, one of the major takeaways from this year's annual report is just the surging growth in high deductible health plans. This chart doesn't go back far enough, but a couple of years ago, it was in the percentage of members covered by high deductible health plans in the commercial space. It was in the teens. It's now at 35%. And as you can see, that trend line seems to be tilting upwards. So, and I don't show the slide here, but adoption is actually across all market segments. It's of course much stronger in the individual and small group market, but even in the large group and jumbo market, you see significant penetration of high deductible health plans. And this is at the same time that you see other cost control strategies such as tiered network health plans or limited network health plans not getting an increase in adoption. In fact, you see a drop, not a large one, but a drop for tiered network health plans. So of the cost control strategies that are getting traction in the market, it's clear that high deductible health plans are well out in front.
Hey,
So,
Ray,
yes.
how does that benchmark to the rest of the country? Do you benchmark? Because this is just the data you have in Mass, right?
Great question. Yeah, we've really focused just on Massachusetts, but the HPC, David Seltz, of course, and then David Auerbach and his staff do a really good job of contextualizing Massachusetts performance versus the whole nation. So I don't know if David can speak to that when he's talking. Off the top of my head, I don't know. I think it's consistent with high deductible health plans are certainly growing nationally. At least that's my understanding. So I don't know if we're ahead or behind that curve, though. We can find out, and we'll find out what information is available and shoot it to the staff at GIC to let you know. Okay, so I think next slide, please. Cost sharing is another issue that has been in recent years increasingly important because more and more, in addition to, well, total spending in the system has, although we now have 2 years in a row where we've been above the benchmark, but even when we were doing relatively well compared to the benchmark, there were still signs that that not everyone was having the same experience of healthcare affordability. And so she has done a lot of deep dives on affordability, but one slide from the annual report that gets at this to some extent is this slide, which shows cost sharing by market sector. So the dark blue bars show the 2019 member cost sharing on a per member per month basis. Over on the right-hand side in the shaded box, you see what that translates to as a per member per month number. So for instance, the biggest blue bar is unsubsidized individual purchasers. They pay on average $99 per member per month out of pocket. And that was up 7.7% in 2018 to 2019. So a significant, I mean, that's $1,200 per year and growing at 7.7%. So highly significant. right above that, you see the Connector Authority with Connector Care. They actually had a large increase in percentage terms, but I think it's because they went from 20 or 19 to $21 or something like that on a per member per month basis. But so you see these trends, they very much follow the market segment where the large group and the jumbo group have lower cost sharing for their members. They have richer, better benefit designs, if you will. You see the GIC, the second from the bottom, with $49 per member per month in cost sharing, and that was actually down 0.6% from 2018 to 2019. So, and then the total market is below that, shown in orange. 2.8% increase was the total market average. $53 per member per month was the total market average for out-of-pocket costs. All right, next slide, please. All right, and I think this is the last slide that I have in my slide deck, but we can talk about sort of any other issues from the annual report that you want to. We do look at quality, so we don't measure, it's hard for us to measure outcomes, but we look at things like the performance of organizations on different metrics. And so this is data from the Leapfrog group for safe and appropriate medication use at hospitals. The far left column is a barcode medication administration. You have CPOE, antibiotic stewardship, which I'm not quite familiar with, but it sounds like, you know, protocols around controlling the use of antibiotics, and then medication reconciliation. The dark blue is fully meets the standard. So what you're seeing is across these four categories of medication management, you're seeing very high, and the light blue is substantial progress. So what you're seeing is that Massachusetts healthcare organizations tend to have a very high and sort of consistently high performance on quality. And so the top line numbers can be a little hard to work with. Sometimes if you drill down and look kind of at a regional level, or, you know, there's variations can start to occur. But generally speaking, we're lucky to have really great healthcare in the state, and that shows up in the quality numbers. I will say we're very eager to look at how 2020 looks from a quality perspective, and then how 2021 looks. We're expecting to see substantial disruptions, of course, in 2020. So some quality metrics is just this steady 98%, you know, sort of compliance rate or performance rate. We would expect to see some things change up quite a bit in 2020, and then we'll be interested to see how quickly folks get back to that same very high level of performance. So the quality work we've been doing, I think, will actually be more revealing in the next couple of years. So I think that's it for the slides in the deck. We do have data, of course, on the different components of healthcare spending, which is something that I know the Commission focuses on a great deal. We look at it both in terms of the total healthcare economy, and then we break it out by the different segments: commercial, mass health, and Medicare. Happy to go into any issues you want, and or to turn back the time to David Seltz, who can really tell us what all these numbers mean.
And my suggestion would be to move on to the HPC presentation, and then we can, because I suspect it'll address a number of questions that commissioners may have on their minds, and we can take questions after David and his team finishes.
Yeah, Matt, I don't disagree with you, but I do see Jane's hand up. So if we could take one question now and then move on.
That's fine.
Well, I just wanted to say that I love hearing the CHIA presentation. Thank you for that. You always come before us with just such rich information. So thank you so much, Ray. I was kind of intrigued because I thought I kind of heard you say that part of what's informing you to, I don't know whether you aggressively expand your data going forward, whether or not the events of this past year factor into that. But I'm just curious when you say expand the database, so a year or two, whenever you appear again, which I hope will be soon, what would you expect us to see?
Sure. Well, right now we have good race and ethnicity data in our hospital discharge database. So we can see lots of interesting things about kind of health equity in the hospitals. If you go outside of the hospitals, we have to rely on claims data, and the health plans don't populate their member enrollment files with reliable race and ethnicity data. So there is a challenge to get the health plans to collect better data so that we can collect better data from them. And there is an effort underway in Massachusetts led by the Executive Office of Health and Human Services to improve the collection of race and ethnicity data by health plans. And we'll be a beneficiary of that. But we're not waiting for things like that. A good example would be, we've always had addresses for people, but we didn't use it other than to make sure for identification purposes, to make sure that if somebody changed health plans, that we could make sure it was the same person we were seeing, tracking them across time. But we would get rid of the names and addresses and assign these unique identifiers to people because we never really looked into the geography of healthcare. Well, we know geography is super important, beyond the 5-digit zip code. We've always had 5-digit zip code information, but that's very hard to look at health equity issues at that level. So we're going to be having the data submitted to us with census block group identifiers, which is a very granular way to look at healthcare spending. So suddenly everything we do, we can break down, how is that different in Dorchester versus Wellesley, and so on. So we're about to really ramp up how we can look at the geography of healthcare in Massachusetts and other things like that. So, and we're working closely with HPC and others to make sure we're not duplicating, but that we're all sort of focusing in the right way. I think we're really going to step up in this state over the next couple of years and do a much better job of measuring this.
Yeah.
Thank you so much for that explanation. That's really.
Thank you for the question.
We'll be digging a little bit more into that in the presentation after the break around health equity.
All right, thank you, Ray.
You're welcome.
So I think now we turn it over to David Seltz and David Auerbach at the HPC. Thanks for joining us.
Thank you and good morning, GIC commissioners. It is such a pleasure to be with you all this morning. As has been stated, we look forward to this presentation and this opportunity to engage with all of you. And before we dive into our presentation, I just do want to reemphasize something that Matt and Ray both said, which is our shared commitment to interagency cooperation and collaboration. It is such a hallmark of what makes Massachusetts so great and our government works so well, is our ability to really think about how we can support each other in advancing our missions. And as you've heard, both HPC and CHIA have incredible data analysts and research analysts. And we want to be able to leverage all of our resources and assets to help you at the GIC achieve your goals, because I think we really do have shared goals around affordability of healthcare, not only for government, but for businesses, for families and individuals, and of course, the GIC members themselves. And as I'm sure you all know, I want to just reflect that state employee health administrators are really becoming an increasingly innovative places where states are really trying to tackle healthcare cost containment strategies through the state employee administration programs. And the policies that the GIC adopts can have market impacts that go beyond the GIC. And as you're thinking about your procurement strategy for next year, we would love to just continue to be a resource to you to think about how the GIC can not only provide great value to your members, but influence the broader market in a way that provides greater value for healthcare for all residents of the Commonwealth. I think there's a great opportunity there. Next slide. So I'm going to do a really quick, brief introduction to the HPC, and then really turn it over to Dr. David Auerbach, who is our research director at the HPC. You can see a lot of different topical areas here, but we really wanted to just kind of give you a sense of some of the major cost drivers that we have identified, that we are focused on, and that we think that there may be opportunities for policy or market changes that can help influence these dynamics, and also to think collectively with you in the future about how we can work together to address these dynamics. Next slide. So the Health Policy Commission was also established in 2012 as part of landmark healthcare cost containment legislation. We were a brand new state agency, unlike CHIA, which was reorganized. And really the central principle of this law, of this goal, of the Commonwealth's efforts over the last 9 years is around this concept of setting a healthcare cost growth benchmark. And this is a target by which the whole, all of healthcare spending in the Commonwealth is tied to, and is intended to constrain the growth in healthcare spending to something that is more sustainable and affordable over time, and that more closely aligns with this overall state economic growth, to avoid that crowding out effect where healthcare costs and healthcare spending just grow so much faster than every other part of our economy or of our government, in ways that lead to more and more dollars going into healthcare and less dollars into other areas of investment. Again, on a government, business, or family basis. So if you think about CHIA as the data hub for all of this, and they collect so much data, we're really the policy hub. So we really try to take all of the data that CHIA collects and then really focus in on specific opportunities, drivers, places where we think that we can do a deeper dive on that data to inform policymaking at the legislature level, at the administration and executive branch level, by market participants. And so, really trying to take all of that data, interpret it, and spit out some kind of policy, a policy agenda attached to that. So Data Hub, Policy Hub. We also have a role in enforcing the benchmark. And the final thing I would just say here on this slide in the vision box is that while yes, cost containment is kind of a core part of what we do, we see this as part of a broader goal of having better health and better care at a lower cost for all the people of the Commonwealth. We think these ideas are not inconsistent with each other, that you can have lower costs, you can have more efficiency, and still have a very innovative and high quality healthcare system that produces great outcomes for patients. Next slide. Very briefly on our structure, we are an independent state agency. I report to a board of commissioners that are appointed by these 3 constitutional officers. Probably looks somewhat familiar to the Group Insurance Commission. And then as executive director, I run the day-to-day operations and staff. Next slide. So just a note on the healthcare cost growth benchmark. So as I said, this is a target for controlling total healthcare spending. It is really an all-in measure. So here we are talking about spending both in the commercial market, spending in Medicare, spending by Medicaid. All the spending that occurs to pay for healthcare in Massachusetts is kind of connected to this target. It also includes what people pay out of pocket and their copays and deductibles. And really we kind of sum all that up and try to track year over year, how is that growing? And for the first 5 years, we set a target as a state of 3.6% annual growth. And then for the last 2 years, we've had an even more aggressive target of 3.1% annual growth. It is a target. It is not a cap. As you will hear later, we can and have exceeded that target. And part of our work is to interpret why that may be, and to also potentially hold certain health plans or healthcare provider organizations accountable to the benchmark. And we have the ability to require entities to take steps to improve their efficiency, to reduce cost and spending if they have excessive cost growth that exceeds the benchmark. Next slide. So we have some regulatory oversight over the healthcare market, but really, in many ways, we're trying to influence the market behavior. And here is a very simplistic way of thinking about kind of 2 levers that we kind of organize our work around. One is around how do we change the market dynamics in a way that is the market is actually has the incentives to constrain healthcare spending. That is not typically how the healthcare markets have functioned historically. So how can we change those market dynamics to meet our goals? And then secondly is how do we have a delivery system that has the incentives as well to provide really efficient, high quality care? So it's both on the delivery system and the financing of that system, but also about how the healthcare market in Massachusetts functions, is organized, and is changing over time. I think an even more simplistic way to kind of put this is that price, if healthcare spending is prices times utilization, or the price of the service times how many services that you're delivering, we are thinking about both of those dynamics together. However, as we'll walk through here today, the primary driver of healthcare spending in Massachusetts and really across the United States is the price of the services. It's not that we're delivering much more services. It's really around what is the growth in those unit prices over time and the variation in those prices among different providers. That's not to say that there are not opportunities on the kind of volume side of this equation, and we'll speak a little bit to that later. But do just want to emphasize, as we'll walk through, the key dynamic that is driving healthcare spending is price growth. So I'll pause there just to see if there are any, well, actually, we're going to keep going through. So I will now turn it over to David Auerbach, our research director, who is going to walk through some of these different areas that we have been tracking and monitoring closely in terms of big cost drivers. Next slide.
Okay. Thank you, David, and hello, everyone. Okay, so David, you're going to advance the slides. These are the subtopics that we're going to be having a quick tour through, some of the trends and important factors leading to spending growth that we see in the data, mostly from CHIA. And this will be mostly covering up through the year 2019, so just before the pandemic. Okay, let's go.
I think, David, you can just call out next slide and they'll advance.
Yep, I'll do that. Okay. Okay, so here to start with, David alluded to this and so did Ray. This is total spending in comparison to the benchmark for each of the years shown since we started this process in 2012. And you can see that in the last 2 performance years, we were above the benchmark. The benchmark was 3.6, and then you can see it jogged down to 3.1 for the last 2 years. So we were quite a bit above that in 18 to 19 spending growth. Okay. Next slide. Okay. So here we are breaking down it by broad categories. What are the major drivers of that spending growth? And what are the major factors as to why we went over the benchmark? The blue in each series, the darker blue, is showing how much did spending grow in that category of care from 2018 to 2019. And so you can see that the largest single category driver was hospital outpatient spending, growing 7.6%. That's quite a bit above the benchmark. And on the bottom, we're just highlighting that overall, combining hospital outpatient and inpatient spending, that those 2 categories accounted for 54% of spending growth in 2018 to 2019. Next slide. Okay, so as David said, prices are the major driver of that spending growth, and we have a lot of slides to show exactly why that is, but we'll highlight just some of the trends on the prices in particular in the next few slides. So what this slide is showing is this is rates that commercial payers are paying hospitals for inpatient stays. And it's an average of all inpatient stays at those hospitals. And the numbers that you're seeing there are in comparison to what Medicare would have paid. And you can see the hospitals arrayed from left to right. And just a note about Medicare rates. What the Medicare rates are trying to do is approximate what an efficient provider, what their cost would be for providing a service. So Medicare rates you can think of as approximately the cost of care for an efficient hospital or physician or whatever. And so Lawrence General there with 155%, they're being paid 50% over what Medicare would have paid. And then on the far right, you have Brigham and Women's and Mass General being paid almost 3 times what Medicare would have paid. And so that's, that is something like almost a 200% markup over cost. Okay, next slide.
I do have a question.
Yes, please.
So if Mass General bills Medicare 290%, do they just get paid what Medicare will pay them?
Oh, sorry. That's what they're being paid by commercial payers.
Okay.
So what they're being paid by Medicare is, basically the same as what everybody else gets paid by Medicare, with the small exception that Medicare gives you a higher payment if you're a teaching hospital, but basically Medicare doesn't care who you are, same rate for everybody.
Okay, thank you.
So here we have a couple of examples of specific, very common inpatient procedures. This is a major joint replacement, a hip replacement, a knee replacement. And here we're just showing the average commercial payment for those inpatient stays, again, by hospital. And here we've colored the academic medical centers in the yellow, teaching hospitals in the orange, and so on. And you can see the range here from about 42,000 at Mass General and Brigham and Women's for that operation to 22,000 at Lowell General or Mount Auburn on the right. And note here that New England Baptist is a specialty hospital that performs almost as many of these as everybody else combined. They have a very high volume and their average payment is on the lower side of average. Okay, next slide. And another example, a C-section delivery. Again, very common procedure, and the variation is not quite as high as the hip replacement, but is still pretty high, from about, again, 24,000 at Mass General to about 15,000 if the same exact procedure, same exact service happens at Mount Auburn. Okay, next slide. This chart, this is the one chart where we're showing national data instead, but we wanted to show you some trends in hospital prices, and this is going right up until February of 2021 of this year. And what this shows is a concerning trend of average price growth for hospital services in total. And this is a monthly measure showing how much did prices grow over what they were a year ago, same month a year ago, year over year. And they tended to be in the 2 to 3% growth range until right towards the end of 2020 and early 2020, when they really spiked up to a degree that has never been seen in this series before. And so this is national data, but we have heard echoes of this from some of our conversations within the state. And this is a trend that I think we should all be concerned with as utilization comes back to pre-pandemic levels or even higher, multiplied by these high growth in prices could lead to a real explosion in total spend. Okay, now let's turn to the hospital outpatient side, which we showed earlier was the largest single driver of growth in 2019. Next slide. This is an example of showing this phenomenon where there's a lot of procedures that could be performed and are performed both in physicians' offices and in hospital outpatient departments. And sometimes the patient can't even tell the difference. Sometimes they look the same, but if you are a hospital affiliated, you can often charge higher rates, facility fee as well as a professional fee. And what you see here is for the three most common procedures that are performed in both of these settings, you see about double the amount being paid if it's performed in that hospital outpatient department. And it was true in 2016, it's still true in 2018, colonoscopy, endoscopy, surgical pathology. So that is an important thing to keep in mind.
Hey, David,
Yes.
Bobby has her hand up. I know we're doing good for time, so I thought I would be okay with having
Absolutely.
be addressed.
Sure. Thank you. I appreciate that. David, I'm very curious about to what you attribute perhaps that huge increase, COVID aside, in hospital prices, that huge spike. So I'm assuming that COVID is part of that spike, but COVID aside, if that's the trend, to what what are the factors to which you might attribute?
Yeah, it's a really good question. I can't be super definitive about it. I can just kind of give you a sense that we've had from talking to market participants and the folks who put that data together from the Alterum Institute. It does seem to be COVID related in that, those prices are reflecting the leverage of the relative leverage of hospitals and health insurers, private health insurers. So as that leverage changes, you would see those prices go up or down. And so there is a sense that post-COVID or during COVID, that leverage shifted somewhat towards hospitals, towards providers, maybe because they were, in the front lines providing a lot of this critical care that we needed in such a a time, but it's hard to know, but it does seem to reflect a shift in that market dynamic and a stronger position of providers, and then providers using that or taking advantage of that market position to negotiate higher prices. That's the best I can say. There's a lot more still to be learned about it, and it's not a definitive answer.
Thank you.
Yeah. Anna, do you have thoughts on that? Yeah.
Well, yeah, I just had a follow-up sort of.
Yeah.
Because the COVID led to the really dramatic closing of all the other procedures that were usually provided by hospitals, for an extended period of time. Do you think that also contributed to hospitals' increased leverage, in the sense that payers really were interested in supporting the hospitals, or keeping them open to some extent?
You mean because of like there was this big drop in a lot of ambulatory non-hospital care? And
yeah, and even inpatient admissions, right, for more typical procedures, like trying to keep, for example, patients with cancer out of the hospital, or other. I mean, did you see that in the data, that the utilization went way down?
We do have I don't know if you saw, but we are in the process of a special legislative mandated study on the impact of COVID on the healthcare system. And we showed we do have lots of utilization data through 2020, and the payers do as well. So we do have more detail on those trends and what's happened in categories of care. But as for that being an explanation for prices, I am not, I'm not sure. It sounds plausible, but I can't really speak to that.
Yeah, no, thank you. That's great.
Okay, but we can share that with you. Okay. Great. Let's move to the next. Okay, so this is another again, very pointed example of same service being provided in different settings and being paid different amounts. Here we have a very routine lab services, a lipid panel, or an A1C test. And you can see the average amount paid, whether it was performed in an independent lab like Quest, in an office setting, or in a hospital outpatient department, and you see about twice the average payment if it's in a Hop D. And you can see those circles in the bottom are showing what proportion of those labs were done in each setting. And so about half of them are done in the expensive setting. Okay, next slide. And now, kind of similar to that inpatient hospital slide I showed earlier, this is the outpatient version of that. And as you know, this varies, but these days about more than half of hospital revenue is derived from the outpatient side. Sometimes it's even as high as 60 and 70% at hospitals. So this is accounting for just as much, if not more, of the inpatient spending. And what you see here is, again, the same kinds of trends, but even more variation, from about equivalent to Medicare on the left to about 3 times Medicare for the hospitals on the right. And you can see even a significant number of hospitals are being paid on average more than twice what Medicare would pay for the same care on the outpatient side. Okay. And in the outpatient category, again, even though we've just talked about price so far, there is also a component of that spending growth that is related to shifting of care from lower cost hospitals to higher cost hospitals. And that's some of what we see in that 2018 to 2019 growth. You can see on the very top, this is just asking, out of all, how many hospital outpatient visits took place at AMCs, community high public payer hospitals, teaching hospitals, and so on. And so that in that very last year, that uptrend in the dark blue and the downtrend in the orange is showing a shift in this site of care towards more expensive hospitals, also driving total spend. Okay. All right. Now this slide is showing, now we're getting back to the changes in prices, and on the price theme, what we did here was we arrayed thousands of the most common procedures that could take place either in an office in the blue or in a hospital outpatient department in the orange, and just asked what was price growth from 2016 to 2018 for these procedures, and just arrayed them in the bins as you see there in the graph. And so the orange bins are showing, for example, on the very far right, about 15% of hospital outpatient procedure services had more than 20% price growth over the 2 years. And the average hospital outpatient department procedure grew 6.1% in price over the 2 years, whereas the average office procedure grew 4.4%. So you see that high price growth for a lot of procedures, more than 10%, 20%, 30%, and on average, higher price growth for things taking place in the hospital outpatient. Next slide. Okay, now we're gonna put all of that together in a total medical expenditure look, and we're gonna be showing different provider groups in comparison to each other. Okay, so the next slide is one of my favorites, and I'll take a second to walk through it. This is showing, and again, thanks to Chia for compiling this data. What they do for the TME, which is again reflecting the total healthcare spending for a person, including prescription drugs, what they pay out of pocket, even non-claims payments. And they've compiled all of that and then taken it back to what provider group do you have your primary care physician at? So basically what I'm doing is taking all patients whose PCP might be at Mass General Brigham. You see that circle on the right. What is the total spending for those patients? Okay, that's what it is. And you can see here in this graph, a rate on from left to right, that total spending varies quite a lot just based on where my PCP is. From, for example, under $500 a month, if my PCP is with the Lowell General Physicians, to over $700 if my PCP is with Mass General Brigham. Or for example, 550 with Atrius. And the size of those circles is just how many members are there with each group. So how big is that group? And on the next slide, well, don't go there yet, but I'll show a bit of why do those spending amounts vary so much? What is behind that? What's causing that? And the theme again is it's mostly about prices. But the other thing that this graph is showing is not just how much care costs in 2019, but what was growth from 16 to 19 on average, annual percent growth. And you can see the benchmark line there indicating that most of these provider organizations had spending growth over 3%, sometimes over 4%. Even in the case of Mass General Brigham, average spending growth was more than 4% per year for each of those 3 years on average. And you do tend to see that some of the higher growing provider groups on the left have lower amounts of growth, so they're playing catch up a little bit. But again, most of these groups have spending growth over that benchmark. Okay. So the next slide, we try to break down that spending a little bit. Now we're going back into the claims data, the APCD, where we can categorize all spending as, is this prescription drug spending? Is this professional? Is this outpatient, inpatient, and so on? And when we break down the spending this way, and you see again, pretty much the same ordering, same magnitudes, but the biggest category of differential is that orange outpatient category. That varies about 2 to 1, just based on where your PCP is. And we've showed in earlier work that what's really going on there is it's a lot of just the higher prices for the same care as we showed before. Because those services are performed in a hospital outpatient department, there's that extra charge, that extra facility fee. And just note that a lot of policy around site neutral payment would try to equalize that across settings. Okay, next slide. Okay, I won't really cover this category too much because we saw a lot in the earlier presentation, but if you just show the slide, David, that graph on the right is showing kind of what we saw before, that as a proportion of all prescription drug branded spending, which is most of spending, the specialty drug category has really creeped up lately and is now more than half of all brand spending. Okay. But I hear you're going to come back to that. One more category is we look at low value care. So although most of the previous talk has been about prices, and prices are the biggest driver of spending growth, we also do want to look at waste, at unnecessary care being delivered, and start a conversation, point out, how much is there and how does that vary by provider group. So the next slides show a little bit on that. We identified through the research a number of categories of unnecessary care that can be found just by looking at the claims data. There are 7 here that you see on the left. And in our APCD, we identified over 80,000 patients got one of these totally unnecessary services and amounting for a fair amount of healthcare spending. And it really varied based on what provider group my PCP was in. Again, that drove how much low value care I got. And that is shown, I think, in a couple of slides. Okay, let's go to the next one. Okay, so before coming back to the low value care, this is showing another thing that we track in the claims data by provider group is ED visit rate. And again, primary care providers, provider groups do have a lot of influence over my number of ED visits and whether I have a potentially avoidable ED visit. They can do a lot of things. They can manage my care. They can make care available after hours. They can point me to, they can have efficient patient portals and point me towards alternatives. And we see here, for example, Atrius on the right had the lowest rate of ED visits and avoidable ED visits among their patients compared to some of the other provider groups on the left. And then on the next slide, we're coming back to that low value care spending by provider group. And again, we do see pretty wide variation. This is fairly under the control of these provider groups who can develop systems. They can flag their EHRs. They can have conversations with their specialists and providers to say, look, there's a lot of things that are no longer recommended for patients. They don't add any value, don't do them. And there is variation in how well provider groups are doing on this. Okay. And I believe, okay, so that's the end. So I'm happy to take questions on any of that or even things that I might not have covered today.
We do have a little bit of time. We can, at the end of the agenda, so we can push back the break a little bit for some discussion and questions here.
Great.
Thank you, David.
Hey, Adam, I see you have your hand up.
Can you hear me okay?
Yes.
Okay. Thank you, David, and thank you, David. I guess maybe a quick question, maybe not. Obviously, the MGB cost and spending really jumps off the page on the various charts and data sets you've demonstrated. And I'm curious, as we see reported in the Globe about MGB's expansion plans in Westwood, Woburn, and Westboro, if you have any sense of what that might mean for overall healthcare spending, and if there's, if as GIC commissioners, we should be worried about increasing costs for both the GIC and our members if the highest, like the significantly highest cost provider continues to take up a larger and larger share of the market.
Yeah, I think I'll let David Sells answer that. That is something that we are thinking about quite a lot.
Yeah, it's a great question. And those expansions are currently under review by the Department of Public Health through the determination of need process. The Health Policy Commission is a party of record into that review process. And we are conducting our own independent review of what the impacts of those expansions will be on healthcare spending, quality, and access. And so don't have results to share for you today, but that is something that we are actively working on and would seek to make that information, public and transparent so that all, other government agencies, including the Department of Public Health, but others will be able to see the results of our independent analysis.
Let me just say a word on that too. Thank you, David, for that response. And I know our respective staffs are working together to help inform the analysis that the HPC is undertaking in this regard. There has been a good deal of press, Commissioner Chapdelaine, as you know, about the MGB expansion with their outpatient facilities. I am concerned about that, and I'll be following that issue closely, and as I said, helping the HPC do their analysis. I think what we read about is a good deal of concern among providers of outpatient services who run the risk of losing a significant amount of their patient panel to these outpatient facilities that'll be part of a higher cost system. One could look at that and say that that is simply competition in the marketplace playing out. But to the degree that it holds the potential to weaken other high-value, low-cost providers of outpatient care. That is an issue that that bears close watching by the GIC and our commissioners. So this is very high on our radar as well. Thank you.
That's
Hey,
great.
Anna?
Thank you both. It sounds like it's squarely on all of your agenda, so I very much appreciate that.
Yeah, good. Go ahead, Anna.
Thank you. I just wanted to echo thanks from earlier to GIA and the Health Policy Commission for these data and these analyses. They're so helpful and can help us really, I think, as a commission, like look to the future. And so thank you. I also wanted to note just on that last comment from Adam that we're also doing some research on this topic in Massachusetts, have some work coming out demonstrating that the integration of physicians with hospitals in particular is leading to higher prices. The actual the quantity of that will be published hopefully shortly. So hopefully that could complement the work that the HPC is doing and provide some information for you on this topic. And as we think about future mergers. The other question I just had for David and David is, when you present these numbers, have you done any case mix adjustment in these analyses? By which I mean, like, that would sort of try to account to some degree for, at least on the spending side, not as much on the prices side, but account for variation in the patient needs going to these systems?
Yes. Right. So I think the only thing that we've shown here that that is on the spending side, I believe, is the low value care side. But I think that you really shouldn't be doing this for any of your patients. But on the total medical spending bubble chart from before, we do have a version of that in the full report that is using the risk score. So that is risk adjusted for patient characteristics. And it's not very different. The kind of the top to bottom differences that you see by provider group there, if that's, let's say a 50% difference, that might shrink to about 40% if you use the risk scores. And part of why I'm presenting the unadjusted numbers in favor of that is we have found in earlier work that those risk scores are not purely picking up patient health status changes, but they are also picking up provider activities towards coding their patients, which does vary by group as well. So there's really no perfect measure of true health need, unfortunately. And so, but we will show them both ways, and people can choose their own adventure on that.
Yeah, no, thank you. I think that's just like a first line, response to these numbers from the providers. And so it's just good to know that the results don't change that much.
Yeah.
So, hey, Toby, I see you've got your hand up, and then Bobby, go ahead and ask your question.
Thank you, Valerie. David, what's your perspective on Optum's takeover of Atrius? Is that going to drive prices up or down or no change?
So I will speak to that. We are currently conducting a review of that transaction. So one of our roles is we receive notice of major market changes like that and do a review and an examination of what we think the impacts of those market dynamics, market changes will be, and make those public. I'm not in a position to give away the answer right now, but we are actually having a public board meeting next week, and that transaction is on the agenda for the release of our results of what we think the impact will be. So I don't want to jump ahead of that. And
can I ask you a generic question then?
Yeah.
What's been the historical impact of prices when an insurance company, whether they either directly or indirectly through a subsidiary, gains control of the primary care level?
David, I don't know if you can speak to the generic theory here on insurer acquisition of physician groups.
Maybe I could speak to maybe just one level broader than that, just in that unequivocally, we always see that hospitals merging with hospitals, or hospitals, as Anna was saying, combining with physician groups does tend to raise prices. Integration between insurers and providers, I think that the literature is really not super clear on that. It can lead to savings, it can lead to increases. I don't know, Anna, if you have a different take on that, but that's my sense. Yeah, okay.
Thank you.
Yeah, I think the message was tune in to the health policies meeting next week to learn more.
Right. Thank you.
Yeah. Hey, Bobby, go ahead and ask your question.
Sure. First, I just want to thank both Davids for your presentation. The data is actually quite fascinating. And I was very curious sort of what you thought about perhaps the next trend for the merger of Harvard and Tufts, and how that might impact the trends.
I'm not sure I understand.
I'm sorry.
David, do you want to speak to that?
Sure. That's something that we have also looked at. I'm not sure if we've commented or said anything publicly on that case yet. But again, we found that to be a lower level of potential concern than the provider consolidations that we've talked about before.
I think in theory, a combined Tufts and Harvard Pilgrim may have greater negotiating leverage with provider groups that in theory could lead to, more restrained price growth. I think we'll wait and see on that.
I don't see any other questions, so I have one last one for you. Do you go to visit with physicians to share this information on the low value care? Do they agree that this is low value care? Is there some sort of standard for what is low value care? And, why does it happen? And why is there such a discrepancy? And do the patients at Atrius do poorly because they're not getting this low value care? Or do they actually do better than MGB because MGB is doing all of these things to be sure, but it's low value? I mean, this is an interesting chart for sure.
Yeah, that's a great question. I'm glad you like it. This was raised by Don Berwick at our last board meeting as well, and we have talked to providers, and nobody disagrees that this is low value care and that these are things that shouldn't be done. And it's kind of a question of how much they focus on it. I mean, I will say that we're looking at a relatively small segment of the healthcare world, and that's partly because it's a little bit hard in the claims data to find cases where, yes, this service really wasn't necessary for this patient, because a lot of things, it might be unnecessary most of the time, but without knowing that patient's full history, there is an argument that, yes, maybe I did need to do this. So it is hard to really be definitive about the universe of care that is necessary. But no, I mean, recent research on your question about, do the patients benefit or do they matter? There was a recent paper that came out that found that in fact, a lot of providers might say, well, yeah, I know I don't really need to do this test, but my patients want it, they demand it, it makes them happy, it makes them feel better. And a study found that no, that doesn't seem to be true. Patients who are getting more of this don't like it. They don't rate their providers with higher experience scores if they get more of this care. So a lot of it really is just, is kind of built-in routines that are slow to change in the healthcare system. It kind of reminds us that a lot of healthcare is an art as much as a science, and a lot of it is amenable to change and should be evaluated all the time.
Yeah. No, well, thank you. This is fascinating, fascinating information. I'm so glad that we have these organizations in Massachusetts. I'm so glad that we are in Massachusetts, and it's really interesting. So thank you. So at this point, we are going to take our break. It's a 10-minute break. So it is 10:40 right now. I would ask everyone to come back promptly at 10:50. So set your timers, and reminder to shut down your camera and your volume, everybody on this. And for the YouTube watchers, we'll be back at 10:50 a.m. So thanks, David, Ray, thrilling to have you present this data to match up with what Willis Towers presented to us. So thank you. Hello, Matt.
Madam Chair.
Yes. Matt, do we want to give people like one more minute to get back, or do we see that people are back? Is
I
there a way
think
to
we've got
tell?
a pretty good representation of our membership that are back plugged in and have their video on. So I think we're okay to proceed.
Okay, let's go.
All right.
Welcome back, everyone, to part two of the GIC meeting. It doesn't happen all that much during the year, but here's our long meeting. So pass it back over to Matt.
Great. Thank you, Madam Chair. If we can move to the next slide. So our colleagues, David Seltz from HPC and Ray Campbell from CHIA have stayed on. We appreciate your hanging with us for this next portion of the presentation. We'll have Margaret Anschutz, our Manager of Healthcare Data Analytics, and incidentally, an alumna of both HPC and CHIA, will give us just a brief review of our prior conversations on this topic, which continues to be a very high priority for me and for the rest of the agency here. So with that, I will hand it over to Margaret.
Great. Thanks, Matt, and thank you, commissioners. So at the top of the HPC's cost trends presentation, you heard David Seltz say that large employers are playing a critical role in guiding the commercial market. I'm going to briefly discuss how GIC is using its purchasing power to focus on health equity. I presented similar information to the Commission in the past, and I think this refresher will help provide context of not only what GIC is doing in this space, but also how we're working with our sister agencies like CHIA and HPC to advance these goals more broadly. So my answer to what we're doing specifically on a targeted intervention in the market around health equity, in a nutshell, our plan is to work with our carriers very closely to craft these interventions in areas where we see the greatest health disparities. So what does that mean? To flesh this out a bit more, I'm going to talk briefly about a program underway at Covered California, which is California's health exchange. Covered California has implemented a nation-leading health equity program whereby they partner with each of their carriers to define interventions in the 4 conditions you see listed on this slide: asthma, depression, diabetes, and hypertension. You will recognize that these 4 conditions affect a large number of people in the population. They have serious, potentially avoidable complications, and there is already strong evidence of racial or ethnic disparities within each of these conditions. Having established parameters of this program, Covered California partners closely with each of their health plans to define interventions and figure out how they're going to measure the success of those interventions. For example, we know from the literature that there is often a gap in adherence to antidepressant medications when you look at medication adherence by race ethnicity. A targeted intervention for this may center on a pharmacist and their ability to remove or reduce barriers to taking medication. So this could look like guiding members to receiving their prescriptions through the mail, If a member has, trouble picking it up in person, or this could also be synchronization of prescriptions, whereby all prescriptions get picked up at the same time, not staggered based on when each is supposed to run out. So those are just a couple of examples. I'd also like to stress that while Covered California is on the leading edge when it comes to operationalizing programs that target health disparities, they and the GIC are by no means the only large purchasers who are making health equity a priority. According to the Willis Towers Watson 2021 Emerging Trends in Healthcare Survey data, 68% of large employers are planning to conduct social determinants of health analyses of utilization by key health conditions, such as the ones listed up on this slide, by 2023. So I think that we're going to be seeing more programs like this being implemented across the country. Next slide, please. This slide shows additional data to demonstrate why it's important that we look at healthcare through a health equity lens. You're looking at national data on asthma as reported by the CDC, cut by race ethnicity, that's on the left, and cut by income on the right. That's the box on the right. What's important to know is that the national prevalence rate for asthma is around 8%. If I were to tell you that without showing the breakdown by race, ethnicity, or income, I would be masking the fact that Blacks and Puerto Ricans suffer from asthma at a much higher rate than 8%. This fact would be masked in aggregate because there are more white people in the population. So their 8% prevalence rate drives the rate for the country. I would argue that it is not appropriate to orient ourselves to prevalence strictly based on aggregate national numbers, as that will always be driven by the most populous group, which in the US is white. And I think we can all see why that would be highly problematic. Similarly, on the right, we see a sharp decline in asthma prevalence across income, suggesting that additional focus on income-based analyses would be appropriate when developing a health equity program. Next slide. Great, thanks. So where are we now? The GIC is in the early stages of collecting race ethnicity data on our membership. As discussed at a prior commission meeting, we have identified how we are going to bring this data into our data warehouse. We have that plan, but in order to ensure the data is comparable to other reporting in the state and thus actionable, we are working closely with our sister agencies at CHIA and the HPC to ensure that we are aligned in our approach to collecting data and building health equity programs. As the largest commercial purchaser in the Commonwealth, we can make a difference in advancing health equity by partnering with our carriers on this matter. However, we can go much further and make a market-wide impact by working with our sister agencies to advance a common health equity agenda, and that's what we're doing. So now I'm going to turn it over to my colleagues at the HPC and CHIA to discuss further what their efforts look like in this space.
Thank you, Margaret. Well, I mean, I'll jump in and turn it over to David. But so this is an area that we're very interested in doing a better job of, in CHIA's case, making sure we've collected the right data, done the kind of foundational analyses, and then made that data available to our sister agencies who, often have more specialized or deeper dives that they want to use the data for. As I said, we do actually have a wealth of information that shines a light on health equity issues in Massachusetts. It's sort of our flagship asset, the all payer claims database. The race and ethnicity data in there is not reliable because the data from the health plans, as we understand it, is mostly by imputation. It's not actually sort of the gold standard is getting members to populate what their race and ethnicity is. So there's a bunch of work to be done in that area, but we are ramping up the number of analyses we do and also trying to get our data better. But also don't discount survey data. There's a lot of power in survey data, and we've recently done some what we call recontact surveys. When we're conducting our surveys, we'll ask if people have an issue with, for instance, affordability. If they say yes, we will recontact them and do a deeper dive on the issues of affordability. So she has been doing more and more work lately to get at some of these issues related to health equity, but it's just kind of a first stage for kind of the more detailed work that other agencies will be doing.
Is there a next slide?
We're now turning it over to David Seltz at the HPC.
Okay.
Sure, thank you. So thank you, Ray. I think wanted to share with this group as well how the Health Policy Commission has been thinking about embedding health equity into our work. And as you and Margaret highlighted, it's been a series of conversations across all state agencies, across state government, across society in so many different ways. And so we really started to engage with our board about what is the HPC's role here last summer, and really advanced a framework for health equity and an imperative for action in our work. And so first we started with an acknowledgement that racial inequities in health and healthcare have always existed for a variety of historical reasons, including structural racism. And these inequities include differences in disease prevalence, access to services, quality of care, treatment practices, and outcomes. The COVID-19 pandemic, further exposed the adverse circumstances facing communities of color. As the data has shown definitively, Black, Indigenous, and people of color have contracted the illness, were hospitalized, and died at higher rates than those of white individuals. And so while we have thought that advancing health equity has always been an implicit part of the HPC's mission, the disparities within the Commonwealth and across the nation really called to light the need to make this effort explicit and a more high priority focus of the agency in our work. And so we are implementing a framework that includes overall principles and values, general questions to guide agency engagement on health equity topics, ways in which our work streams can incorporate health equity. We've developed a health equity practice and style guide to inform all of our communications and publications, and are developing a framework for accountability to keep the agency on track and committed to this. So I'm going to highlight a few of these elements of our framework and approach in just a few slides. So on the next slide here, this is a graphic that we have adapted, I think, from an Attorney General report. And this is just a framework that illustrates that there are many structural inequities that impact health outcomes: homophobia, ableism, xenophobia. And while many of these prejudices have impacts on upstream social determinants of health, for example, on food access or housing, racism has been proven to not only have an impact on these social determinants, but in and of itself has a harmful impact on health. And so we really have centered racism because it both influences social determinants and is an independent factor in health, and made that central to our work in thinking about implementing a health equity framework to guide the HPC's work. Next slide. So in an effort to make what we thought was implicit explicit, we changed our mission statement and proposed and had adoption from the board to update our mission statement that puts health equity front and center. So you can see the changes here to our mission statement, putting equitable healthcare as one of the key goals, and really highlighting that our goal of better health and better care at lower costs is intended for all residents of the Commonwealth. And this really is consistent with our statutory mandate. The legislature adapted our mandate to explicitly tell the commission that we should establish goals intended to reduce health disparities, as you can see here. And so we think that this explicit recognition of equity as part of our mission is clearly contemplated by our mandate. Next slide. So we propose a series of just principles to guide our work in incorporating health equity into all of our work streams. And just to quickly walk through these 5 principles. First, the HPC acknowledges the pervasiveness of health inequities and the systemic racism that underlies them, and that eliminating inequities is integral to our mission. Second, that the HPC will embed health equity concepts in all aspects of our work, and we'll apply it to our core strategies, which I'll walk through in a second. Third, that our work will be informed and guided by those with lived experiences of inequities. Fourth, that the HPC itself will educate ourselves on the role of inequities and promote diversity, equity, and inclusion in our own workplace in order to fully cultivate a culture of anti-racism within our agency. And then finally, and I think this goes to the main point that Margaret and Matt have really highlighted, is underlying all of this is a concept of partnership, that advancing health equity in the Commonwealth is a shared responsibility, and that the HPC will actively seek opportunities to align, partner, and support other state agencies, including the Group Insurance Commission, the healthcare system, and other organizations who are all working together on these goals. And on the next slide, these are just some of the ways that we seek to influence the healthcare system through research and reporting, through partnership, through convening, and as a market watchdog. And we think within each of these types of roles, there are ways that we can embed these concepts. And I'll just give you one example of that in the next slide, which is this is research that is part of our COVID-19 impact study that David Auerbach mentioned earlier. And here, really wanting to take a very specific focus on the disparate impacts of COVID-19 on different racial and ethnic groups, and using great GIA data. This is hospital discharge data, which, as Ray said, does have more comprehensive race and ethnicity data in it. Made an explicit decision to analyze what were the impacts for rates of hospitalizations for these different groups. And what is being displayed here in the blue bars is, for that particular group, what is their share of overall hospital admissions, and then compared to what was their share of COVID-19 hospital admissions in the orange. And where you can see that the orange bars are higher than the blue bars, that is a disproportionate impact, or that group represents a disproportionate share of COVID-19 hospitalizations. And so you can see, and this is broken up by age categories on the top and bottom, but for Black individuals and residents of the Commonwealth, an almost twice as higher rate of share of COVID-19 admissions compared to overall admissions, even greater disparities and among the Hispanic populations, and then kind of a flip reverse of that for white populations, where their share of COVID-19 admissions was lower than the share of overall hospital admissions. So this is just one very brief example of how we're trying to use data to help inform and understand how our healthcare system is, treating and providing access and quality to care to all residents of the Commonwealth. And I think, as Ray said, and as Margaret said, as we continue to evolve our data sets, a commitment to being able to use this data to really help inform both our understanding, but also to inform action. So with that, I have some more slides here, but I think in the interest of time, I won't present on them, but thank you very much.
Thank you, David. Let me just say a couple of comments before we open it up for discussion here. I think the amended mission statement really stands out to me. I think, as you were saying that, I pulled up the GIC's mission statement, and as your prior mission statement was, so is ours. I think there are, you could certainly look at our mission statement and say that there is equity sort of implicit but not explicitly called out as a part of our mission, and I think we should be moving in that direction to also do the same with our mission statement. I'm very interested to hear more about the style guide. I think that is something that can be really helpful to us, specifically since we're producing materials that are member facing. I think we need to be need to view all of our communications through this important lens. I will note for the commissioners too that, as we've talked about race and ethnicity data being an ongoing project, and we have some near-term opportunities with imputation to gain greater understanding of the disparate impacts on different subgroups of our membership. We are also taking this lens to our day-to-day work. So for instance, our member survey, the conjoint survey that we've discussed here in the past, we have included data points to ask members about how they identify on racial and ethnic lines, as well as income lines. So that will help us to have a little bit more understanding, more granular and richer understanding about how different groups of our membership view the strategic questions that we face. And, I think one of the things that I want to emphasize that Margaret noted in her opening comments here is that what's really essential here is to understand and reveal areas where there are disparate impacts on our members due to social determinants of health that otherwise would get lost in the averages, knowing that the overwhelming majority of our membership is white, and that would really, it just doesn't give us a full picture of the challenges that we face, and therefore the types of changes or programs that we need to be putting into place to better serve all of our members. So I'll stop there. I'm eager to have some conversation with the commission about this. I'm excited about the opportunity to work in collaboration with my sister agencies here on this area, which seems really, really ripe for that sort of work. So questions, comments, discussion, we're happy to open it up here.
Yeah, so I see one hand up. Eileen, go ahead and ask your question.
Thanks. It's more of a comment, and I just wanted to commend HPC and Chia for looking at this. You may be aware the Mass Taxpayers Foundation issued a report, and we do plan on having kind of working groups focused on some of the topical areas in our report, one of them being healthcare disparities. So I did hear your offer to partner and would very much welcome the opportunity to do that.
Oh, I like that. Go ahead, Adam, I see your hand is up.
Thank you, Valerie. I just wanted to echo the thanks. I know several meetings ago, I joined other commissioners in asking Matt and the team to prioritize a focus on issues of race and equity, and they certainly committed to doing so. And now, along with HPC and Chia, this is really buoying. I think you can't manage what you can't measure, and I think there's lots of measurement still to do. But it seems to me that you're well on your way. You've listened to the things we've asked of you, and you're moving down that road. And I just wanted to express my appreciation and thanks.
No, I think that's a great comment, Adam. Thank you. Go ahead, Joe.
Yeah, I'd also like to say thank you. For those of us who represent labor, most of us represent very diverse workforces, and this will benefit us with our members. So thank you.
Nice. Yeah, thank you. Go ahead, Jane.
I just am echoing every other comment that's been made. And I'm particularly delighted to see this level of progress and seriousness attached to this subject. And I'm so extremely grateful for this presentation. I would like to just highlight a couple of things. As you think about focusing on diversity, equity, and inclusion, may I suggest that another word that could be added is belonging. For many of us who live the experience, as you so correctly said in your slides, and that you'd be guided by those who live the experience, it's kind of difficult to express, but you're kind of always wanting to feel that you belong where you are, that the environment is such that it doesn't just welcome you or that it includes you, but that it actually doesn't question whether you have a right to be there. And there's a sense sometimes when you walk into any particular setting, whether or not you're met with "why are you here" as opposed to "glad you're here and you belong here." So again, thank you so much for this. The data to me has always been painful by any measure that we look at, be it the wealth gap, be it representation in corporations, be it COVID deaths as it affects the Black and brown communities. It's very painful, but this is a presentation that's very uplifting and hopeful. Thank you enough for this great work.
Yeah, no, well said, Jane. Hey, Bobby, I see you have your hand up.
Yes, thank you. I just wanted to echo what my colleagues have said regarding the presentation. And I'm actually, delighted to see this. I mean, and, the data, this is, it is not surprising, of course. And I'm very sort of interested in how we're going to use this data. What are we, going to do? How are we going to intervene? What is, I'm also interested in, not just knowing, how many of our members are Black and brown, but how does that relate to the retirees, right? Like, I have no idea what that number is, and also children, because children who are Black and brown are also adversely or impacted on a greater scale than white children when it comes to, for instance, asthma or depression now in certainly middle school and high school age children. And how are we going to use this data to make a significant change? So I want to just, sort of express my appreciation as well to CHIA and to HPC, because this is wonderful to have this data. So thank you.
No, that's really well said, Bobby, and an excellent question. And I would also, include Margaret in that question, because it seems like she's taken the lead in getting this data specific for the GIC so that it can be actionable. But I want to speak for you, Margaret or Matt. Bobby asked a good question.
Yeah,
Sure.
Go ahead, Margaret.
Sorry. Sure. Yeah. No, I'm happy to take that. So, maybe I didn't make it explicit when I was talking about Covered California, but I think what I want to communicate is that I am doing and have done a sweep of programs across the country that involve carriers and best practices, or at this point, I think it's really promising practices, intervening on matters of health disparities. We know where the health disparities are. The literature is robust there, but what hasn't happened, much to the healthcare system's embarrassment, I would hope, is that hasn't been operationalized in a lot of places. And what Covered California has really done is just that. They've operationalized it. They've made health equity part of their mission statement. They have operational goals to meet, where people's performance reviews are tied to meeting those goals. And they have partnered with the carriers to, again, look at the disparities in their population, identify what evidence-based interventions exist, and implement them in partnership, as I said, with the carriers. That I think will ultimately move towards performance guarantees and goals with the carriers and the purchasers around achieving those reductions in disparities. But I think, again, we're very much in the sort of developing these programs, developing that stage. And I've been watching covered California very closely because I think they're way out in front on this. And so I see us doing a lot of the same things that they're doing, but with a Massachusetts specific lens and GIC specific data that we're looking at.
Yeah, that's terrific. That's a great answer. Thanks, Margaret.
Thank you. Thank you,
So
Margaret.
thrilled to have you on the team. You're doing such good work, and your commitment to this is definitely noticeable. So thank you. Go ahead, Christy. I see your hand up.
Thanks, Valerie. And thank you, Margaret. That's all really helpful. I guess I'm just trying to get a handle on when should we start to see some change in the data? Like realistically, is it a couple of years? Like I have no idea how long it takes to implement, much less to actually see changes in the data.
Yeah, this one's really tough. And so it has to do, there are two parts to this. One is getting data that is actionable. And two is, setting a baseline once we have that actionable data, setting the baseline with the carriers, and then building this program. So what I mean first by actionable data, we have a 3-point plan for collecting race ethnicity data, but really the gold standard is self-reported. So what we need is our members to self-report their race ethnicity, and we have a plan to make that happen within the next couple of years. All right, so say I have that data in 3 years, then we share it with the carriers, and we start working with them to develop the programs. And I've got to do a lot of work around a baseline to know what we're starting from, and then we can move into serious implementation. So I think it's realistic that we have numbers on disparities and the success of our interventions at like 5 years, which I certainly wish I could reduce that amount of time, but I want to do this right. And that means building a very solid foundation in the data. And it also means not rushing anything, getting the data right. So that's what I'm expecting.
That's great. Not great news on the timing, but
I think so. Margaret rightly focuses on the sort of gold standard where we're headed over a period of years. I do want to continue to emphasize that we will use every opportunity that's available to us leading up to that and in parallel to that to gather data that captures these dimensions of our membership, including the conjoint survey that I mentioned. But I think we also can rely on some of the data here that the HPC has presented that demonstrate broadly where those areas of disparity exist. And while we may not have our own specific data for our members until sometime in the future, we don't need to wait for that in terms of making adjustments to our coverage or implementing specific programs that are targeted towards subgroups of our membership. I think our carriers aren't waiting. I'm happy to say that while they are, as Ray has noted, there's a long way to go for the carriers to capture that data on their end. There's also some really interesting and creative and innovative work that they are putting in place, programs that they're putting in place. So we're not waiting, but that is, part of the longer plan for us, and we will go where the data leads us. I think that's the simplest answer to the question about how we will use the data. I would say too, just to sort of leave the race and ethnicity data element aside, we are also putting a good deal of thought into steps that we can take as an employer of 67 employees on how we can create pathways for different members of our professional team. I think we benefit from overall pretty positive numbers for the diversity of our staff, but we have a lot of work to do in our management ranks. And I don't think we can make a whole lot of progress there unless we're giving some real intentional focus on this dimension of that work. So we will, this is not the end of the discussion at the commission. This is very much still the beginning of this discussion. It has many dimensions to it that we will continue to engage with the commission on. I think our work on the as an employer is an area where we'll be back likely in the fall. We're working on our diversity plans as we speak, and engaging with our HR director to do a better job on that front as well. I think the last thing I would say to the commission is, please continue to challenge us. You've challenged us from the very beginning on this topic, and we take that challenge seriously, but we can also benefit so much from your expertise here in areas where we need to do more.
That's great, Matt. Jane, you go
Well,
ahead.
one comment. I just wanted to say that Margaret's approach, I completely get it, and I think that she's right, and to do it right, and it will take time. I'd also say that if we're going to challenge, continue, and I love that you said, Matt, because that shows your humility as a leader, and I appreciate that personally. But in order for us to challenge, we need to understand our history. And I would ask you what you've been taught in school about historical literacy. And my experience would say that many of us have not been taught why we're in the condition that we're in right now, why this data exists, and why it's so complex. This data, for those who have lived this experience, they know the impact of these numbers without charts. They're human beings that are attached here. And it's been around for years. I mean, I've been in Boston all my life, and I can tell you that the data, as I live it and see it, has been extraordinarily depressing for Black and brown communities. So what I'm so proud of today about the commission and the leadership of the commission, and for the presentations today, is that what we're doing is we're surfacing the unsaid, because many of us don't have a clue what this history has, the damage it's caused, as was so well put out, not just to Black and brown communities, but to our society as a whole. We have no clue. And so what can we use the data for? Hopefully to inform policy has been suggested, and to take actions that mean something. There are many organizations that get into the diversity thing, and they have programs left and right. And at the end of the day, they cannot measure the value of those programs. So data is essential to try to inform policy and to get results from efforts that are value laden. So again, I'm sorry for the long-winded commentary, but I am just absolutely proud to be part of this commission. And I hope that our state surpasses California. Thank you, Margaret.
Yeah,
and thank you, Matt.
Jane's competitive side.
Valerie, for this discussion.
Oh, well, thank you, Jane. All right, well, this has been great, and I love what we're doing. I'm proud to be part of the commission. So thanks for all the comments. Let's move on, though, to some votes. We are in the final stretch of this meeting, so I'm going to turn this over to, is it Andrew or Jim?
This goes to Jim.
Of the trust fund.
Yep, this goes to Jim.
Okay. Hi, Jim.
Hi, everyone. Good morning, or close to good afternoon. Good to see you all. I will be relatively brief here, but we do have a couple of votes today, in addition to the usual finance update. So if we can go to the next slide. Some of you who have been here for the past meeting in June may recall that annually we request authorization to use funds from the Employee Trust Fund to supplement IT, administrative services, and communication budgets. These funds are only used if needed. It provides some continuity to projects and also protects against cost overruns. There is a process for approving these projects. Both the vendor manager, the project manager, the CFO, and the executive director review the projects to make sure they're appropriate for the use of these funds. Historically, the commission has supported these requests. last year, of the year we're currently in, FY21. We have not spent any money from these funds. The regular administrative budget has covered all our needs. But again, there could be a scenario in the future where that may not be the case. May I go to the next slide, please? So this is some detail on the requests. The IT requests are similar to prior years. There's a list of projects here and uses that I won't go through in detail. The amount of money, again, is also similar to last year. Next slide, please. This is a list of the administrative and member engagement potential uses of these funds. Again, very similar to prior years. No particularly new initiatives here, but there's some detail here. If you have any questions on it, I'd be happy to answer. Also on this slide, I want to point out there's a mistake on my slide. The first one this year, so please forgive me. On the bottom, the temporary employee request, we do have one temporary employee. It says here we have none, but there is one temporary employee currently working at the GIC. And our temporary employee request is to have authorization to hire up to 10 temporary employees if needed. There's no plan currently to use those employees. It just provides us some flexibility if we had something come up that required us to use temporary people, say, to do data entry or something like that if we had a crunch situation. Again, these hirings are always reviewed by the executive director, CFO, and director of HR to make sure they're appropriate. Next slide, please.
So go ahead, Jim.
Sorry, Matt. So before we entertain a motion for this request, I would entertain any questions you have on what I went through there fairly quickly.
Jane, do you still have a question, or is that your hangover from the last one? I think you're on mute, so I'm thinking it's one. So I don't see any questions. This is just to be sure everybody knows, this is a request to spend up to. It doesn't mean that they are going to spend this much money, and historically they haven't. So
right, it's not to exceed amount. Yes.
Yeah, it's a not to exceed. So I don't see any questions. So at this point, I'll entertain a motion to approve that our CFO can pay certain expenses from our trust funds as recommended here today.
So moved.
Oh,
Seconded.
sorry.
Okay. And so at this point, I'm going to turn it over to Andrew for roll call, and I am a yay.
Thank you, Madam Chair. Vice Chair Kaplan,
Yay.
Designee Archibald,
Yay.
Designee Butler,
Yay.
Commissioner Shabbat,
Yay.
Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Yay.
Commissioner Kleinard,
Yay.
Commissioner Davis,
Aye.
Commissioner Giron,
Yay.
Commissioner Edmonds, still on mute. Commissioner Gentile,
Yes.
Commissioner McEnany,
Aye.
Commissioner Jennings,
Yes.
Commissioner Sinenko,
Yay.
and Commissioner Sullivan.
Yes.
Commissioner Edmonds, she may have stepped away. In any event, the motion is passed. 15 with 1. We'll consider Commissioner Edmonds an abstention at this point.
Thank you, Andrew. And for those of you who are listening on YouTube or curious as to why Commissioner Rodriguez was not roll called, she had to leave the meeting early today. So wanted to make sure that was noted. All right, you're back on, Jim.
Okay, thank you.
More money, seems
More
like.
money, right? So this is a request to spend money from a different trust fund that wasn't anticipated from last year. As you may go to the next slide, please. The our life insurance vendor is changing. So we're changing, as you know, from the Hartford to MetLife. And as part of that, we're doing the final contract closeout and all the reconciliations of the accounts. And during that process, it was discovered that a particular group, the retired municipal teachers, had a balance of $1,684 owed to the Hartford. This is part of a lot of flow of funds going back and forth between the GIC and Hartford. But this particular expenditure requires the approval of the commission in order to access the rate stabilization reserve or trust fund for the purposes of paying the Hartford for this final settlement. So this vote is to authorize the GIC to release those funds to the Hartford to finalize the contract settlement. If you have any questions on that, I would entertain them now.
I don't see any questions, but I always like to ask. So how many people are still left in the RMT?
Oh, well, the RMT is the large group. I think what you're thinking of is the EGRs.
Okay, sorry, yes.
We're down to just a handful of folks, but the RMT, I don't have that number exactly, but it's a large group. It's a large
Okay,
group.
and we're helping to offset anything so they don't have to bear the burden of this change of vendor.
Mm-hmm. That's correct. And these are funds that they already contributed to this trust over the years. So it's money that they've contributed to this fund. So it's an appropriate use to pay their expense from
Okay.
this fund. So it's a
right.
good matching of uses and
It
sources.
sounds terrific. It does indeed. And we've done this before. So, okay, at this point, I'll entertain a motion that we authorize the commission to spend this money to move from Hartford to MetLife.
So moved.
Second.
Okay, so I'm going to turn it over to Andrew for roll call, but I am a yay.
Commissioner Kaplan,
Yay.
Commissioner Archibald,
Yay.
Commissioner Butler,
Yay.
Commissioner Shabbat,
Yay.
Commissioner Chapdelaine,
Aye.
Commissioner Choate,
Yay.
Commissioner Clonard,
Aye.
Commissioner Davis,
Aye.
Commissioner Giron,
Yeah.
Commissioner Edmonds. Oh, sorry, she's not present. Commissioner Gentile,
Yes.
Commissioner McEnany,
Yes.
Commissioner Jennings,
Yes.
Commissioner Staneko,
Yay.
and Commissioner Sullivan.
Yes.
The motion passes unanimously.
Great. Okay, Jim.
Thank you. Thank you, commissioners, for those votes. I just want to acknowledge, as Commissioner Tim Sullivan has noted to me, he will need to step away from the meeting now. So thank you, Commissioner Sullivan, for joining us and hanging in for the vote.
Thank you. Have a good day.
Okay, bye, Tim.
Bye.
All right, last kind of bit of finance stuff. Jim, you got for us?
Yes, I will go through this relatively quickly too. And thank you all for the vote. We very much appreciate it. This is our final update for this year. So June, as you know, our year ends on June 30th. We will come back in September with a final accounting of the year. This is the last time you'll see it before the year actually ends. So I won't touch on everything. The information's in your packet. I think a lot of it at this point is self-explanatory. But there's a few interesting tidbits of information if I can mention them. On this slide is the medical claims week to week, and it's, I think, a fairly interesting slide. Is the red line, the horizontal red line, is kind of the pre-COVID average level, and as you can see, the blue line, which is our actual spend, has pretty much approached the pre-COVID level. So I think that's a trend that we've been seeing come to fruition over the last several weeks and months, and it feels like we are finally there. So hopefully people are getting the care they need, and we're paying the claims as they come in. Next slide, please. And here's a look at the COVID claims by month. It's a little bit surprising, and I think I mentioned before, we're going to take a more thoughtful dive into this in the data warehouse with Margaret and her team. But here's the spending, just the gross spending. You can see COVID claims have begun to recede. There's a bit of a lag here. Again, this isn't as informative as we would like, but I think it's a good informational piece for you all to be aware of, that there's been significant COVID claims. They continue to remain fairly high, and we'll come back to you in the fall with a little bit more detailed look at this and what it meant for our members.
So Jim, are the vaccines included from, January down, or it
They
seems
would be. Mhm.
that so these numbers include the vaccines?
To the ones that made it to our billing
Yeah.
at this point, right? Because there's a little bit of lag there too.
That
So
makes
we'll be able to pull that apart in detail, maybe in September when we come back, have a little bit more detail on what was vaccine, what
Yeah.
was treatment, and what the level of treatment was. But it'll be interesting to see. But yes, if people were vaccinated and we were billed, they'd be in here.
And just a reminder that the vaccine itself is paid for by federal funds. It is simply the cost of administration that is borne by the GIC and reflected in claims.
Okay.
Correct.
Our
Thank
active members. Yeah.
Yeah. Thank you, Matt. All right. Thank you, Jim. I
Next
wanna
slide,
take
please.
time.
Oh, sorry, Madam Chair. Go ahead.
No, it's fine. I'm just moving us along, even
Yep,
though
I'll be quick. I'll get to the punchline here. These are our payments. These are just informational for all of you to have to look at your leisure. Next slide, please. This is the enrollee shares, so the employees share the same payments, as you know. 2 more slides and we'll be done. So this is our budget. As you can see, the shape has actually been pretty good when you consider that it was a COVID year and all of that. We've been fairly accurate with our projection. And if we could just skip to the last slide, we'll get to the dollar amounts here. One more. And so as of now, we're pretty much predicting a $92 million under budget variance, which is more or less what we thought we would be for the last several months. So it's played out again, more or less as we thought. That's a 4% variance. The next few weeks that'll move around a bit, but this is relatively stable situation. So with that, I'm happy to answer any questions. Again, we'll come back with the final accounting in a little more detail on the COVID spend in September. And if I could just take 2 seconds, I really want to have a little shout out and thanks to my accounting team, who won't hear this, who's not here, but they've taken this whole operation, as everybody at the GIC did, from a very paper intensive in-person operation to a remote operation, and have still been able to report and pay over $3 billion in payments and revenue and all that while keeping us compliant. So it's an outstanding job by those folks. And I just I'm the one you see, but they're there. They do a lot of work, as everyone at the GIC does. So small but mighty team of 4. I want to thank them for their work on this year.
No, that's so nice, Jim. And that's the sign of a good leader. So thank you, Jim, and your whole team. It's good. All right. We're going to move on to open enrollment. I believe this is our last topic. It's always nice to hear from Paul and Cameron.
Madam Chair, I'll sort of go through this kind of quickly in the interest of time, but I'll highlight some important numbers. This slide here represents the member touch points during annual enrollment. So going quickly through it, the blue line represents the online contact forms. These are members that went to our website and submitted questions to us during annual enrollment. We received about 1,500 inquiries through our website. The gold represents the number of calls GIC staff handled. You'll see that we took almost 14,000 calls during the 4-week period of annual enrollment. The gray, light gray, represents cases and documents that we received during annual enrollment. Over 18,000 documents came through our system. And the dark gray represents the website views during annual enrollment. Most popular hits are turning 65, retirement, the benefit decision guides, and information on the new premiums for July. So Jeannie, if you go to the next slide. What this slide represents here is, on the previous slide, the 18,000 documents that we received during annual enrollment. One interesting thing to note here is DataBank is our scanning vendor. These are people that complete forms and send them to our vendor, and they're scanned electronically to GIC. The DocuSign is the people that go out to our My GIC link, the system we stood up in December of 2019, and they complete their forms electronically. So one thing to note here is that our new system, My GIC link, has outpaced the paper enrollment for the first time. So we're getting more forms through the My GIC link than we are through our DataBank vendor. And it's a little over 50% split. Last year, it was about 60-40. 60% of our members completed the paperwork and 40% through the electronic. So we've increased the My GIC link by about 10% this year, which I'm happy with. Next slide. What this slide represents at a very high level is the results of annual enrollment and the net gain by health plan for the members. So on the left-hand side, you'll see the numbers in black. Those are members that are newly hired to the Commonwealth during annual enrollment or picking up coverage for the first time for July 1st that they may have been employed and never had GIC coverage. And then it also represents the number of members that transferred to that plan during annual enrollment. The right-hand side represents people that have left state service during annual enrollment, transferred out of the particular plan, which gives us the net gain or loss by plan. You'll see that limited network plans, the Fallon Direct and the Primary Choice and the Tough Spirit, as I mentioned last month, continue to see a decrease in the net of the enrollment over the last couple of years. So one thing to note, you'll see on the transfer to and the transfer from column at the bottom, there's 2,778 members transferred during annual enrollment. So on the next slide, Janine, if you could advance it. This is the result of the transfers during annual enrollment. I know the print is a little small, but we wanted to get it all into the document. So this shows you where everybody went, where they transferred out of and where they transferred into. Very quickly, if you look at the top line, Always Health Partners, if you read that across from left to right, the last column gives you the number of members that transferred into that plan during annual enrollment. And across the top, it gives you where they transferred out of. So for instance, Always Health Partners, 3 people come out of Fallon Direct, 4 from Select, 8 from Harvard Pilgrim, Primary Choice, et cetera, all the way across. If you take the left-hand column and you read down, that is the number of members that transferred out of that plan. So using Always Health Partners, again, reading it down, they had 168 people transfer out of the plan. And if you read it across, they had 101 people transfer into the plan. One thing to note here, Unicare Plus continues to be the most popular plan. You'll see in the lower right-hand corner, 641 members transferred into that plan. And that has been a trend over the last couple of years.
Hey, Paul.
Sure.
This represents only those members who chose to make a change. There are the rest of our subscribers, is it 200 and something thousand for a total of 400,000 plus, remained with their existing plan, but these 2,778 were the ones that made a change. Am I reading this the right way?
Yes, these are the people that made the true change. On the previous slide, it incorporates these changes plus any new additions to the health plan and anyone that has left the health plan. But this is true transfers. These are people that moved around during open enrollment.
And is there any time soon where we'll mandate that every single one of our constituents have to review their health plan and either validate that they want to stay with it or see that they could make a change that's more beneficial to them?
I think if Matt wants to speak to that, I think that is something that will evolve with the next health procurement and what the results are, what will be coming out, and whether or not we want people to look at the benefits or any changes that come up. So I think that's to be determined.
Yeah.
And Matt, if you want to add anything.
Well,
I go ahead.
Highly encourage the GIC, I think for the good of our members, to evaluate their plan every year and to be able to see if it's meeting their needs from a cost perspective as well as from an access perspective. I think it's a good policy to get into. I think employers in the private sector do this every single year, and it does help. It does help those who do it become better users of their health insurance.
You took the words right out of my mouth, Madam Chair. And this is very much on our minds, as Paul said, as we head into the enrollment that will result from the next procurement.
Yeah, I just want to encourage us to really keep our eye on the ball. We thought we could never do YouTube videos and show our constituents these meetings every month. But when necessity struck, here we are doing it. So we can also do an open enrollment for all of our constituents every year, and they will find value in it. Well, my hope would be that they would.
Yeah. All right, Janine, if you go to the next slide, just 2 points to worth noting is our retiree dental plan continues to be very popular. We had 898 new retirees enroll in the plan for the first time for July 1st. And the total enrollment is over 40,000. Last year during annual enrollment, we were just about 39,000 in the plan. So it continues to grow and is very popular with our members. Buyout applications, what that is members who elect to cancel their GIC coverage and elect a 25% payment, 25% of the full cost premium that they get a check monthly from the GIC to buy out of their health insurance. And that continues to, those applications, nothing surprising, anywhere between 100 and 125 per buyout period. Several years ago, GIC expanded the buyout so that we have one during annual enrollment and we have one also in the fall. Next slide, Janine. This one is just a snapshot of the membership for July 1st. So this is what it looked like with people leaving, terminating, transferring coverage to give you the 421,869 total membership, and it splits it between state and municipalities.
Thank you, Paul. I think that's it on the enrollment summary. Now we'll hand it over to Cameron to give us a little bit more detail on the use of our FSA plans. I know there's some interest on the part of several commissioners to understand a little bit more detail on its usage. This, I think, will be the beginning of our reporting on that, but we wanted to give you what we have today. So, Cameron.
Thank you, Matt, and thank you, commissioners. The chart that is in front of you now shows our overall enrollments for the last few years since we made the switch to the current vendor benefit strategies. As you can see, we did see a relatively significant decline of about 5% in unique members, most of that being driven by reduced participation in the healthcare FSA plan. The DCAP participation went up slightly, and we expect that to actually continue, particularly once school is back in session and more daycare providers come back online with rising vaccination rates throughout the Commonwealth. We'd also like to point out that the amounts that people are electing to withhold and contribute into these FSA plans has actually increased, even though we've seen a decline in overall participation. Any questions at this point?
I don't see any, Cameron.
Okay.
All right, well, it sounds like you're tracking on this, and it's some interesting trends given, but it's been an interesting time.
Well, yeah, and as the note at the top of the page indicates, we want to remind everyone that we have extended the grace periods for the previous fiscal year as well as the current fiscal year. So, we're still waiting to see how those plans are going to shake out. There's a fairly substantial amount of money available for claim payments that has not yet been utilized. So we won't know exactly how fiscal 20 and fiscal 21 shook out until the end of this year.
Okay, great. Hey, Bobby, I see your hand is up.
Yes, thank you. I was just curious, Cameron, about the balances remaining, which I know it's a little too early since that's been extended, but I'm assuming that some of the decrease in participation is related to, the balances that people expect will not be utilized and that they will lose.
That is my guess, and it's supported by the current balances we have on file. But with these, we extended the fiscal 20 grace period for an entire 12 months. So until those have a chance to close out, we won't really know where things stand. But yeah, the enrollment data and the balances, particularly in the healthcare FSA, would indicate that those unused balances probably did depress participation for fiscal year 22.
Thanks.
Thank you, Bobby. Thank you, Cameron. Anything else to add, Cameron?
Nope.
I don't see anybody else's hand up, so we can move on as
Thank
we
you.
go to a wrap. Move towards a wrap. Go ahead, Matt.
Sorry, I was on mute. Thank you, Madam Chair, and thank you all commissioners. This really wraps our extended meeting here today. It was a lot of presenting. I typically like to have these meetings allow for as much back and forth and dialogue as we can do. Given our assignments over the last couple of months, it's been a little bit more coming from us. And I would look forward, as I mentioned at the top of the meeting, towards discussions, particularly around our developing procurement strategies in the fall and into the spring, that I think will be a little bit more dynamic in nature. So I appreciate everyone's patience and your willingness to stay on for an extended meeting here as we close out the fiscal year. It's been an extraordinary year. I'm enormously proud of the management team and the rest of the staff here at the GIC. One of the things that may not be apparent, even just from Paul's presentation, is that the enrollment was conducted again with staff almost completely remotely at a time when we have also really leaned into our staff to help us prepare for the move and throw out a lot of documents and shred a lot of documents and send a lot of documents to storage. And we've also been extremely hard at work standing up our member portal, which we're very excited to say has had a soft launch with 10 pilot agencies last week, and it all went extremely smoothly. So we are asking an enormous amount of our staff. We have over the course of this year. And I'm just thrilled and excited to tell you that they've risen to the challenge. I don't think that would surprise anyone, but we are only as good as our team here in serving our members. And I'm proud of the work that we're doing here. So thank you all for your service over the course of this past fiscal year, and we look forward to a really exciting fiscal 22 ahead.
Thank you. That's well said, Matt. I am very proud of the GIC team, and I love being part of it. We have a great commission. We get some really great staff. Always focused on serving the constituents and to the commissioner. So very appreciative of this last year. It's been quite a year, but we learned a lot, and what doesn't kill us makes us stronger. So I don't think we have any more business. I think this is the last item. Is there anything that we need to bring up, commissioners or GIC? Any new business? All right, well, I don't see any hands. I'm not hearing any ideas for new business. So at this point, I will adjourn our meeting and wish you all a wonderful summer. And when we get back together in September, we'll have more news on when we might be in person, because I would love to see all of you again. All right. Happy summer.
Thank you.
Thank you.
Have a great summer, everyone. Thank you. Thanks
You
for
too,
all the
Bobby.
hard work.
Yes, thank